for sparing your time and joining us.
Sir, you're on mute, sir. Prakash, sir, you're on mute.
Yeah. Okay. Thank you very much. Can I finish my inaugural address?
Sir, 2 minutes, sir. We are just starting.
Okay.
Dr. Bharti Rajshekar ma'am is also here. So
Okay,
another 5 minutes. So we will take.
Good morning.
Another 5 minutes, is it? Okay,
Start
because
now.
okay, no.
Madam, you are online now.
Yeah, we'll start now.
Yeah.
So, good morning, everyone. It gives me great pleasure to welcome you all to this cardio-obstetric series. So, we will be having this is from the Society of Maternal Fetal Medicine, Mysuru chapter, as well as the JSS Medical College. So, we have today our chief guests, Dr. Bharti Rajshekar and Dr. Prakash Mehta, who is our guest of honor. I now call upon our president, Dr. Sushma Dev, to welcome the gathering, following which we will have the inaugural address. Over to you, Sushma.
Yeah, very good morning, all the eminent faculties and our dear colleagues and delegates. It gives an immense pleasure to invite you all to this virtual platform. So we as a team of SMFMI, the Society of Maternal Fetal Medicine India, and Mysuru chapter. So the society is formed with the motto of enhancing the obstetric practice and updating ourselves and all our clinicians in the management of medical obstetrics. And for the past several years, we have been enduring and venturing our updates on all the medical diseases, and we have concentrated on hypertension in pregnancy and autoimmune disorders. And in this today's virtual platform, so we have executing 3 series of discussions, CME programs on cardiac obstetrics, which is an upcoming and it's a major medical disorders. And for this, we sincerely welcome all our eminent faculties. It's a great honor to have you all with us. And I'm sure this program of virtual series will enhance our clinical knowledge and help us to manage our mothers in a better way. So at this platform, it's our great honor that our president of KASOGA, the Karnataka State Obstetrician and Gynecological Association, the very eminent and the leader of Karnataka, we have Dr. Bharti Rajshekar ma'am. Can I have ma'am CV? So
Yes.
she's the driving force for our Karnataka society. So ma'am really requires no introductions. Everyone, all of us, and we know her. She's very active, and every day she's part of so many CME programs, I'm sure, and it's a honor that we have ma'am with us. And ma'am, we welcome you for this.
Thank you.
Over to you, ma'am.
Thank you, Dr. Sushma. A very good morning on a very pleasant Sunday morning to all the esteemed faculty and the participants. And I would like to first congratulate the Society of Fetal Medicine of Mysore for doing this commendable job. And I also express my pranams to the cardiologists of Mysore, who have joined together to update us about the updates in pregnancy and cardiac disease or cardiac disease in women, which is sometimes I would like to say a less discussed topic. But of course, we know that whenever we have women with a cardiac disease, we OBGYNs do get perturbed at some time, probably because we feel that the morbidity or the mortality may be increased in these women who present to us with cardiac disease on one hand. And the other hand, when we have a fetal scan done and they come to us with any, even a single marker like an echogenic focus in the heart or any sort of a congenital anomaly detected by the fetal scans, we need to make very, very informed, we need to help the couple make informed decisions. And that in that perspective, we as OBGYNs need to be updated as to how, as a team, we can manage cardiac disease very effectively in the present scenario. And even fetuses detected with cardiac disease can be managed unless they are life-threatening, when we would need to offer them a medical termination of pregnancy as a choice of management. But with the advances of therapy in cardiology, whether it be in adults or in pregnant mothers or in the fetus. It is very, very rare that we need to offer medical termination of pregnancy, or we need to be perturbed according to the manage women with cardiac disease. Well, thanks to the reduction in infection rates in the neonates, in the childhood, like rheumatic fever, we do not see rheumatic heart disease to that extent we would see in our postgraduate days, where it was a very, very common scenario. But I would now like to tell the OBGYNs here, please, in your clinical examination, do not forget the stethoscope. Please take the stethoscope and put it on the lady's heart once at least, because we have seen women presenting to us late in pregnancy, or they're presenting to us in mid-trimester with a rheumatic heart disease or any other type of a cardiac disease, because we have failed. We think that the stethoscope has fallen into disrepute, but no, I am a very, very strict proponent of clinical examination, and we have to follow whatever we have studied in the Chamberlain's or the clinical practice guidelines, which was the Bible for us when we were walking around in the ward rounds. Your stethoscope is not just an ornament for you today. Please use the stethoscope every time the woman comes. Put your stethoscope on her chest and see S1, S2. Are there any murmurs? Are there any signs of cardiac enlargement? Because you all know that cardiomyopathies are very common in peripartum, antepartum, and postpartum scenarios, and we fail to recognize such events. So I would not contradict some studies which show that it is effective in practice to do a cardiac echo for all your pregnant mothers in the early or late third trimester of pregnancy, because you could pick up this cardiomyopathies in these women who may be asymptomatic in the antepartum period, but become symptomatic either intranatal or postnatally, and we have seen increased incidence of morbidity in such women. So please, I think in certain states like Tamil Nadu, they have made this a mandatory practice that a cardiac echo is done for all women in the antenatal period. And to go further on this, I would also say I always do a cardiac echo for all women I take up for elective surgeries in gynec practice also. For example, a lot of comorbidities, hypertension, diabetes, and she has a fibroid or she has endometriosis. She is going to undergo prolonged laparoscopic surgeries. Please include it in your armamentarium that do a cardiac scan for them, so that we know that the patient and ourselves can be safe in our practice. So I would like to congratulate the Society of Fetal Medicine again for this commendable job of taking up this series. And I would request Dr. Sushma to extend it further to all the other Kasoga societies. We do have a medical disorders committee in Kasoga. So let us take up this series in that platform also. And I thank the Cardiac Association of Mysore for giving me the opportunity and bestowing me the chair, the chief guest chair in this very prestigious webinar. I wish this webinar a great success, and I'm sure this is going to make inroads to all the participants in their clinical practice, so that we can deliver better health to our women and children. Thank you very much for the opportunity.
Thank you so much, ma'am, for your enlightening words. And of course, as ma'am rightly said, we should never forget our clinical skills. And we definitely look forward to your support. And we will work in together with the team of Kasoga and Medical Disorder of Pregnancy Committee. And thanks for the extended support, ma'am. And definitely in next sessions, we will be part of your team as well.
Thank you, Sushma.
Yeah, ma'am. So now I request our president, Dr. Prakash Mehta, sir, to address as the guest of honor. After that, we'll be having a formal inauguration with the lightning of lab. Prakash Mehta, sir, over to you. Dr. Prakash Mehta, sir, is our team leader, the man with a vision. So he's always been a great support, and he has held our hands in launching our society. And he's the person who brought in World Congress of iShip to India. It was a huge success, and he put India and, of course, our SMFMI in the world platform. So we are greatly honored to have our team leader, Dr. Prakash Mehta, sir.
Sushma, if sir is busy, I think we can just go for the lamp lighting and then we can start the program.
Sir is in a conference. He has just logged in. Just make a call. Meanwhile, we'll have our formal inaugurations with lighting of lamp.
Sagar, I think we can start with the lamp lighting.
Thank you. May this the light enlighten us with all our wishes and will bring us the great knowledge. And we pray to the goddess of knowledge, Ma Saraswati and Ganesh ji, for always to be part of our educational endeavor. I think sir is busy right now. We should proceed with the scientific sessions. Over to you, Dr.
Joining in.
It's after the first talk. Maybe we'll start with the session.
Okay, we'll start with the session. If sir joins, then we can just ask him to say a few words. So once again, welcome everyone to this cardio-obstetric session. I will now introduce the chairpersons for the first session. The chairpersons are our own president, Dr. Sushma Dev. She's an associate professor and unit chief at MMC RI, Mysuru, and is also the director and chief consultant at Aishwarya Hospital. So she is the president of the SMFMI Mysuru chapter and has various publications and has delivered the prestigious Hiremat Yuva Oration in Kasoga 2021. Our other chairperson is our very own Dr. Mamta, professor and HOD Department of OBG in JSS Medical College, Mysuru. Ma'am has various publications to her credit and has presented a lot of papers at the international and national forum. So over to you, Dr. Sushma and Dr. Mamta. You can introduce the first speaker, Dr. Malini. Sushma, you can take over.
Yeah. We're pleased to have Dr. Malini with us from Hyderabad, Fernandez Hospital. She's a senior consultant and she's done a fellowship in high-risk pregnancy, and she's currently consultant in Fernandez Hospital. Her areas of interest are adult cardiac disease and connective tissue disorders and obstetric critical care, many others. She has several publications in high-risk obstetrics. We are pleased to have you, Dr. Malini. Over to you to render your lecture.
Thank you so much for the kind introduction. Can I be allowed to share the screen?
Yes, I think you can share your screen, Dr. Malini.
Yeah. So is my screen visible?
Yes.
Yeah.
So good morning to all. It is my proud privilege to be a part of this August gathering, the first of its kind cardio-obstetrics virtual online webinar. So we as a team can work wonders. The cardio-obstetrics team does not only limit itself to the cardiologist, the maternal fetal medicine, the obstetrician, and the anesthesiologist, but the nursing staff who take care of these women, the pharmacists, the social workers, all these form an important part of the cardio-obstetrics team. The incidence of cardiac disease in pregnancy is quoted at 1 to 4%, and we all know that the incidence is increasing these days, as Dr. Bharti Rajshekar has rightly put. So we are seeing more mothers with advanced maternal age entering pregnancy, where there is increased incidence in comorbid conditions like morbid obesity, hypertension, diabetes, etc. And also with advances in the surgical and medical management of the congenital heart disease, more children with congenital heart disease are entering into the childbearing age and are becoming pregnant. So cardiac disease has become the leading cause of non-obstetric maternal mortality. So if you look at the ROPAC registry, that is a register of pregnancy and cardiac disease, which is a multinational registry which involves more than 50 countries. This was published between 2007 to 2018, and they have noted an increase in the number of high-risk pregnancies belonging to modified WHO class 4, that is where pregnancy is almost contraindicated. The incidence has increased from 0.7% in 2007 to 10.9% in 2018. If you look at the Embrace UK 2023 data, apart from the COVID, so cardiac disease is one of the leading causes for maternal mortality, and along with the thromboembolic diseases and mental health conditions as well. So we now know that this is a very important evolving specialty which we need to be working as a team and helping these women. So I would like to take you through two case scenarios. These may not be very rare. We may have come across these scenarios at least once in our practice as obstetricians. The first case is of a 24-year-old primigravida with an uneventful antenatal period. An emergency cesarean section was done for non-progressive labor. In the immediate postoperative period, she developed shortness of breath. On examination, she had a low saturation, 88% at room air. Auscultation showed a mid-diastolic murmur and an ejection systolic murmur with bilateral basal crepitations in the lung fields. A TD echo was then done, and she was diagnosed to have moderate mitral stenosis and a moderate mitral regurgitation. A second case, an 18-year-old primigravida booked at 14 weeks of gestation. She is a known case of cardiac disease, but she did not have the documents with her at presentation, and the attendants only told that she had a hole in the heart. So at that time, a nuchal scan was done because it was a period for the scan between 11 to 13 plus 6 weeks, and it was told to be normal, and she's asked to review back with the documents at the time of TIFA, that is at 20 weeks. So when a thorough clinical examination was done at 20 weeks, she was found to have central cyanosis, grade 2 clubbing, a systolic murmur, and a saturation of 82% on room air. A review of records at that time showed that she had a cyanotic congenital heart disease, that is a ventricular septal defect with pulmonary atresia. So what does these two case scenarios tell us? The first case, the subtle signs or symptoms that the woman had may have been mistaken for the physiological changes of pregnancy. She was not picked up, she was not evaluated, and she was landed up with an adverse maternal cardiac event, that is pulmonary edema, in the immediate postpartum period. In the second case, though she is a known case of cardiac disease, we have lost our clinical skills. We have stopped using our eyes, ears, and hands. That is where we are moving away from our clinical examination and relying more on the laboratory diagnosis, and we have missed a very serious condition of a cyanotic congenital heart disease. If we had picked up early in pregnancy, we may have asked for a termination. So these two cases underline the importance that we obstetricians may be the first point of contact for many of these women, contact for healthcare for many of these women, and many cardiac diseases which were not diagnosed prior may be unmasked with the stress of pregnancy. So if you look at the data from the prospective registries, the ROPAC data shows that 8.2% of the women were diagnosed with cardiovascular disease in the current pregnancy. And data from the MPAC registry, this is our very own data from our Madras Medical College, that is the Madras Medical College Pregnancy and Cardiac Disease Registry. This is published in 2023 by Dr. Justin Paul. In their cohort, 50% of the cardiac vascular disease in pregnancy was diagnosed in the current pregnancy. So this is again a huge burden. If you look at the spectrum of the disease, in our Indian data, most of the women have valvular heart disease more than 50%. Congenital heart disease is 33.6%, and others account to 12.3%. These others will include arrhythmias, cardiomyopathies, ischemic heart disease, or other metabolic heart diseases. If you look at the ROPAC registry data, the valvular heart disease is only about less than 30%, and more than 50% is the congenital heart disease. So this is again the data from the Justin Paul and the MPAC investigators, where they noted that among the women who have been diagnosed with cardiovascular disease in the current pregnancy, the rate of maternal adverse cardiac events is almost 18.2%. That is a very significant number. And this underscores the importance of us to be very watchful for the signs or symptoms of cardiovascular disease in pregnancy. So with this brief introduction, I would take my talk forward. I would talk about the hemodynamic changes in pregnancy, mimickers of cardiac disease, algorithms or red flags that need to be in place. A few slides about the cardiac risk stratification and evaluation of pregnant patient who is diagnosed with cardiovascular disease. So coming to the cardiovascular adaptations in pregnancy, the cardiac output, stroke volume, and heart rate increase. The pulmonary capillary wedge pressure and central venous pressure remain unchanged. The systemic vascular resistance, pulmonary vascular resistance, and the colloid osmotic pressure reduce. So all these changes will predispose the mother to increased incidence of pulmonary edema. So if you look at the timeline, the changes start as early as the first trimester, peak due in intrapartum, immediately, that is in the second stage of labor and immediately after delivery, and the changes slowly revert back to normal in over a period of time. So, and data have suggested that only 30% of these adverse cardiac events occur in the antepartum period, and most of them are seen in the early and late postpartum period. So the so-called fourth trimester of pregnancy is a very important period for these women with cardiovascular disease and pregnancy. So how to suspect? Again, back to basics, the art of history taking, we are soon losing this art, but we should pull up our socks. We should not miss any of the symptoms which can indicate that the women may be having something more than the physiological changes of pregnancy. A thorough general examination and a cardiovascular examination is important.
We are unable to hear her.
Auscultation are of paramount importance. So we should be very much aware of these mimickers, which may be pertaining to the symptoms, pertaining to the physical findings or the auscultation findings. But there are some algorithms that can point us in the right direction. In the self-reported symptoms, if the woman has a dyspnea at rest or orthopnea, chest pain at rest or with minimal exertion, palpitations that are associated with syncope or near syncope, and extreme fatigue, this should prompt us to evaluate this woman immediately. Rest of all the symptoms, we can either reassure or proceed with a non-emergent evaluation. Coming to the examination, any heart rate more than 120 beats per minute, systolic blood pressure more than 160, respiratory rate more than 25, oxygen saturation less than 95, elevated JBP, a loud systolic murmur more than grade 3, and a diastolic murmur or an S4 heart sound, bilateral basal crepitations and a marked edema. These should prompt us towards a immediate evaluation for any underlying cardiovascular disease. Most of the women in pregnancy, they do not exert themselves physically. They have restricted activity. So these symptoms may be masked. So sometimes we may need to ask some leading questions like, how many flights of stairs can you walk up with ease? Is it 1, 2, or none? Can you walk a level block? Can you sleep flat on bed? If not, how many pillows do you need to use? Does your heart race? And when your heart races, do you have any symptoms? Do you have any chest pain? And is the chest pain associated with exercise? So these are some of the very few leading questions that we may need to ask the women. And if there is any pointers, we should have a low threshold for testing when the symptoms warrant. Our basic tests include ECG, transthoracic echocardiography, but we should not hesitate in asking for a Holter or a transesophageal echocardiogram when indicated. We should remember that the exercise testing may be submaximal in pregnancy. So a 6-minute walk test to know the functional status of this woman is very important. And exposure of these women to radiation is one thing that all the obstetricians fear, but that should not hold us back when indicated. We should ask for investigations, including a chest CT or a cardiac catheterization or even an MRI if it is warranted. There is another talk regarding image in pregnancy. I will not go into the details here. And NT-proBNP is one cardiac biomarker which is gaining importance in our armamentarium in predicting as well as diagnosing women with cardiovascular disease. And any level more than 128 picogram per ml in early pregnancy is a predictor for adverse cardiac outcomes during pregnancy. So the California Maternal Quality Care Collaborative have come out with 2 algorithms. The first one is for women with red flag symptoms or women who have a personal history of cardiovascular disease. So any red flag symptoms like shortness of breath at rest, orthopnea, with the women needing to use more than 4 pillows, a resting heart rate more than 120 beats per minute, and a systolic pressure more than 160, respiratory rate more than 30, and saturation less than 94. Prompt evaluation and a referral to a cardiologist and a maternal fetal medicine specialist is warranted. Any woman with a personal history of cardiovascular disease, even without the presence of these red flag signs, warrant a evaluation by a cardiologist. The second algorithm is for those women who do not have a personal history of cardiovascular disease or who do not have these red flag symptoms. So this algorithm takes into consideration the demographic features, the self-reported symptoms, the vital signs on examination, any abnormal physical examination findings. If any of these will amount to more than 4, a combination of these more than 4, then we should evaluate these women promptly with the help of an ECG, an echo, or a chest X-ray, or a NT-proBNP, and prompt referral. If any of these examination results are abnormal, prompt referral to a cardiologist would save the day. So the screening algorithms were evaluated in women who had died of cardiovascular disease, and they have found that 88% of cases would have been identified as high risk for severe cardiovascular disease in women who were asymptomatic if we had used this algorithm, and 93% of symptomatic women would have prompted further cardiovascular disease testing, thus avoiding the mortality. So once we diagnose a heart disease, assessment of risk is of paramount importance. That should be done in conjunction with a high-risk obstetrician and a cardiologist. We have various general and lesion-specific predictors and risk scoring systems, and newer lesion-specific risk stratification tools are also coming into vogue. So we should assess the risk based on the medical history, the functional cause, oxygen saturation, presence or absence of arrhythmias, exercise capacity, and the natriuretic peptide levels. So we have the NYHA classification ranging from no limitation of physical activity to inability to carry on the physical activity or symptomatic at rest. And we have the Carprec 2 score system, which have 5 general predictors, 4 lesion-specific predictors, and 1 delivery of care predictor. But this Carprec 2 is for general heart disease. It is not lesion-specific. It includes both congenital, valvular, and ischemic heart disease as well. And this is mainly developed in the Western population. The Sahara score is mainly for the congenital heart disease, and we have various parameters which are given various points in the risk assessed as per the total score. The modified WHO class is currently the most accurate system for risk assessment, and it is prospectively validated in various settings and has to be found useful in categorizing these women with cardiovascular disease and pregnancy. And we have classes 1 to 4, where one is there is no detectable increased risk for maternal mortality, and these women can be delivered in the local hospital. To class 4, which is extremely high risk for maternal mortality and morbidity. The maternal cardiac event rate is 40 to 100%. And these women, when seen in the pre-pregnancy period, we should advise them against pregnancy, or when seen in the early pregnancy, we should discuss termination. And these women should be delivered in a referral hospital with a cardiac backup. So one of the new scoring systems is the Davy score that is developed by the JIPMER team. So it is adverse cardiac events, especially in valvular rheumatic heart disease in pregnancy. This is a lesion-specific score. And a score of more than 5 is associated with a high risk of adverse cardiac outcomes. And I'm happy to inform that Fernandez Hospital have been in collaboration with the ZIPMER team for the external validation of this Davy score, and we have submitted the paper for publication. So from all these risk scoring systems, we know that there are predictors for maternal cardiovascular events, and any functional NYHA functional class of 3 or 4, a history of prior cardiac event like a prior history of cardiac failure, transient ischemic stroke or arrhythmia, severe left heart obstruction, reduced ejection fraction, pulmonary artery hypertension, cyanosis, NT-proBNP more than 128. These are all the predictors for adverse cardiac events during pregnancy. Not to forget the fetal risks, risk of miscarriage, stillbirth, fetal growth restriction, prematurity, the teratogenicity of the drugs that the mother is using, increased risk for bleeding, and risk of inheritance. This risk of inheritance is quoted anywhere between 3 to 50% based upon the parent, the lesion that the mother has. If it is a Marfan's, the risk of inheritance is 50%. If it is a VSD or an ASD, it is between 5 to 10%. Anyway, we have a talk on genetics and heart disease in the subsequent lecture, so we'll be hearing about that in detail. So coming to the prenatal care of women with heart disease in pregnancy, preconception assessment and counseling is the best case scenario, but rarely do we see the women in the preconception period. And even if we have seen them in the preconception period, these women do not follow up with us regularly, and they do not follow the medications, and they may come back with an unplanned or an unwanted pregnancy. So it is always a teamwork with the cardio-obstetric team. Complete risk evaluation should be done at the first prenatal visit, and it should include a thorough history taking, a complete physical examination, a basic ECG, transthoracic echocardiogram, and assessment of the functional status if needed with a 6-minute walk test. And they should be repeated as and when needed as the pregnancy advances. Remember, risk assessment is a dynamic process. It is not that first visit you have seen the mother and categorized as a MWHO 1 or 2 and that's it. No, it is a dynamic process, and the risk has to be calculated at each prenatal visit based on the symptoms and the results of the investigations. And again, the investigation should be interpreted with caution, keeping in mind the changes in pregnancy. Like, in ECG, some changes are normal, the physiological ECG changes that you see in pregnancy. So these have to be interpreted with caution, and the investigations has to be interpreted based on the lesion. Genetic counseling where indicated. Do not forget assessment of the fetus, and a delivery plan should be in place well in advance. So management for plan for delivery should be taken as early as in the early 3rd trimester, involving the cardiologist, the maternal fetal medicine specialist, the obstetrician, anesthesiologist, and the critical care specialist. And this should be circulated to all those who are involved in the care of this pregnant woman cardiac disease, including the nursing staff, including the registrars or the fellowship students or whoever who are on floor and taking care of these women during delivery. So what lessons have we learned from our maternal mortality reviews? That the cardiovascular disease-related deaths could be prevented through early diagnosis and treatment. Half of these serious cardiac complications are preventable, and the cardiovascular risk factors such as advanced maternal age, hypertension, diabetes, obesity, they play a significant role in the cardiovascular disease-related mortality. So we have a lot of challenges in terms of inequalities in healthcare access, lack of knowledge at healthcare provider as well as the patient level. We do not have many robust screening strategies, misdiagnosis and delay in the diagnosis. They all this contribute to morbidity and mortality. But we do have an opportunity in converting these challenges to chances by increasing the access to the healthcare, improving the access to healthcare across all levels, and improving the knowledge of the healthcare provider through such webinars as we are doing it today, and also creating awareness among the patients, bringing into practice some robust screening strategies. And we may adapt some of those algorithms to suit our own clinical scenarios, and we may implement them in our routine day-to-day practice to help screen these women and avoiding delays, delays in diagnosis or a misdiagnosis. So my key messages today would be always listen to her symptoms, hear her, and screening strategies should be in place. We should have a low threshold for investigations to help in the early diagnosis. always it is a teamwork. It is not only the cardiologist or only the obstetrician who is responsible for her care. A lesion-specific counseling and care is required. And beware of the effects of medication on the mother and fetus. Develop customized risk stratification tools. So conventionally, we have been told that the regurgitant lesions are well tolerated in pregnancy, but more and more data that is coming in show that severe MR and PR also they have a high risk for adverse cardiac events. So lesion-specific risk stratification tools and care as per the risk for that woman is the care that we need to provide for these women. So together we can help these women to have a safe pregnancy and childbirth. Thank you.
Malini, excellent lecture. So as to summarize what you said, don't take any symptoms, ignore any symptoms, take every symptom seriously to differentiate it from whether it is physiological or pathological. And of course, a cardio-obstetric team completely should be involved in evaluating such cases. So I think there are a few questions in the chat box what I went through. I think Dr. Bharti would like to know, is there any checklist for analyzing these symptoms?
There is no proper proposed checklist as such, but we can incorporate the algorithms that the California Quality Care Initiative has provided, and we can modify them as per our setup, and we can incorporate into our own screening strategies.
Thank you, Dr. Malini.
So I think each center has to have their own checklist, and always make it a practice. All obstetricians should have a practice of going through this checklist before coming to any conclusion. So if there are any other questions, yes.
And as Dr. Bharti Rajshekar has rightly put, we have to use our clinical skills and not entirely rely on the investigations or the labs.
Yes, use your stethoscope first.
Yes.
Yes, eyes, ears, and hands, all of them.
I said first our eyes. Excuse me, we should use our eyes, our hands, and then the stethoscope.
Yes, ma'am, you are right.
And then put everything together in our brain and analyze first, I think, before we write the laboratory investigations.
And very importantly, we should maintain the institutional database, and we should come out with our Indian statistics. Most of the times we quote all the other references. So with a huge clinical load, we should maintain our Indian registry, and we should sum up all the institutional database and come out with the algorithms and our own protocols. Thank you, Dr. Malini. That's indeed a great talk. Now we have Dr. Prakash Mehta in line. So over to you, sir. Sir is the president of SMFMI India. So sir was busy in his scientific program in Hubli. Sir has joined us right now. Over to you, sir.
Good morning, and thank you for inviting me for this program. I'm sorry I was a little late since I'm in SDM Medical College, Dharwad for a pre-eclampsia program. But I'm indeed very glad that the Mysuru Society has come up with this beautiful program on the cardio-obstetrics, because it's something that is really required now for two reasons. One is that the cardiac that an average obstetrician face is definitely rare, maybe 1 or 2 in a year for an average obstetrician, not attached to an institution. And secondly, the type of cardiac cases that are coming in are changing. Before I would see almost my 80% of my cases would be rheumatic, heart fever, and other 20% would be of other kind. But now, the ratio is almost 50-50. And I'm sure that in the next few Western countries, the rheumatic heart disease would definitely be lesser. So I'm really glad that Dr. Sushma, Dr. Hemapriya and the entire team has put together this program. And I wish you all the best, and I wish all the delegates a very happy learning. And thank you again once more for waiting for me. Thank you.
Thank you, sir. Your words are truly inspirational. We'll move on to the next session. We have Dr. Santosh K. from Jayadeva Cardiac Institute. He will be presenting on risk assessment and cardiac imaging. Sir is a graduate from Jayadeva Institution, and he's done his fellowships, FACC, and he's got a list of cardiac fellowships and a leading practitioner of cardiac in Mysuru. and he's got several awards due to his excellence. And over to you, Dr. Santosh.
Good morning, everyone. Thanks a lot for the kind introduction. First of all, I would like to thank SMFMI Mysuru chapter for giving an opportunity to be part of this program. I think my slides are visible.
Yeah, you're visible.
Visible. Thank you. I think today I have been given this topic, risk assessment and cardiac imaging in pregnancy. You see, with a lot of advancement in medical care, a lot of patients with pre-existing heart disease, whether it's a acquired or a congenital, they live up to this age and fortunate enough to bear children. This is going to give us a lot of challenges when we treat these women. When we see a spectrum of heart disease in pregnancy, we can have either a lady with a known heart disease, where we have sufficient time to counsel them, prepare them, and make them go through a smooth and safe pregnancy and delivery. Other way around, we can have ladies where the pregnancy itself unmasks a pre-existing heart disease, and a lot of times they come to us in acute emergency, either in acute pulmonary edema or some kind of a acute symptom. They come to us, and it will be a challenge to treat them. And one more group is pregnancy itself can lead on to de novo cardiac conditions. That's also a challenge. We'll go through how to assess risk in these individuals, how to image them. Initially, as a common disorder, maybe we'll take up individual in the later slides. Just to brief, I think it's been discussed by Dr. Malini and Dr. Prakash Mehta. Because of multiple reasons, cardiovascular disease is increasing over a period of time. A lot of things are positive because they're able to live up to this age. When we consider multiple factors, maybe 10% of pregnancies is complicated by one or the other cardiovascular disorder. As was discussed earlier, in our country, it was rheumatic initially. Now, over a period of time, at least in Tier 1, Tier 2 cities, congenital heart disease, it's increasing day by day. I don't want to go in detail of all these things. There are a lot of adaptations which happen in a mother when they're pregnant. That's going to either precipitate or initiate a pre-existing disease or a new disease which is cardiovascular related in a given lady. All these things, I think it's been discussed multiple times. I don't want to go in detail of all these things. Either it can be hemodynamic, vascular, hematological. Ultimately, it can cause various disorders depending on whether it's a prothrombotic milieu, it's some kind of a endothelial damage, or fluid overload, or an increase in stress in a given individual. I think all these symptoms, whether it's a normal symptom or abnormal symptom, has been discussed by a previous speaker. We should be knowing how to pick up an individual who may be having or harboring a cardiac disease. All symptoms in a given pregnant lady may not pinpoint towards a organic disease. If an individual has paroxysmal nocturnal dyspnea, gradually increasing dyspnea, exertional syncope, it predominantly talks about a new pathology which may be cardiovascular related in a given individual. And conditions like cyanosis, clubbing, diastolic murmur, persistent arrhythmia, evidence of significant pulmonary arterial hypertension, or clinical examination points towards the same. I'm going through a slide faster because all these things has been discussed by Dr. Malini, my previous discussant. And when you come to assess these people, I think there are a lot of laid out parameters. There are a few scoring systems, few things we have to give ask ourselves or a patient. Are we dealing with organic disease? If organic, is that lady able to cope up with pregnancy or not? How things will be? What kind of precautions will take? What modification, what suggestion we have to give them? What should be the counseling? It has to be teamwork. Coming to the maternal, we have a various scoring systems, ZARA, CARPEG, and modified WHO, which has been most commonly accepted. In addition to that, we should know what is the baseline disease we're talking about. Is it stable, optimized, or not? Does this disease can worsen over a period of time? Are we dealing with some kind of a prothrombotic, arrhythmia related, or a heart failure related things, or we are dealing with some kind of a pulmonary arterial hypertension? Various kinds of parameters going to tell us or make us predict how smooth will be the course of pregnancy and delivery, and what will be the fetal output. Is the fetus at risk? Is the mother at risk? And how best we can manage these individuals. As my previous speaker talked about, modified WHO scoring system, see, it basically talks about a pre-existing condition in a mother which can predispose to various problems we are going to face in pregnancy or delivery. Based on this classification, we can anticipate and advise them either against pregnancy or some kind of modification or some kind of a frequent monitoring of this individual. As per this classification, diseases which does not require extra care falls under WHO 1. Diseases requiring termination or against pregnancy falls into WHO 4. Simple conditions like mild diseases like mild pulmonary stenosis, PDA, mitral valve prolapse, or some ectopics falls into WHO 1. Whereas easily manageable conditions like atrial septal defect, ventral septal defect, repair of supraventricular arrhythmias, which can be easily treated with medications. Turner syndrome without heart dilatation falls into WHO class 2. Moderate conditions like mild LV dysfunction, non-obstructive hypertrophic cardiomyopathy, mild mitral stenosis or moderate aortic stenosis, Marwitz or hereditary thoracic hypo diseases without much aortic dilatation comes under class 3, and more aggressive, more complex diseases comes under class 3 and 4, like severe LV dysfunction, severe RV dysfunction, complex congenital heart disease, either of frontal circulation or untreated, moderate to severe obstructive lesions like either mitral stenosis or aortic stenosis, aortopathy with enlarged thoracic aorta. All these things come under either class 3 or 4. What does it tell? It talks about what is the possibility of maternal cardiac event rate. As you go from 1 to 4, the chance of developing a complication increase from almost 2.5 to 100%. That's what it talks about. Higher the WHO class, higher chance of maternal morbidity and mortality. And the way we counsel, way we involve the heart and pregnancy team or a obstetric team is more important. In WHO 1, maybe once or twice is sufficient, whereas in advanced stage, it has to be more frequent, and the advanced stage requires an expert center for management of pregnancy and cardiac disease. And as discussed earlier, a lot of other scoring systems, especially CARPEG and ZARA, being used, where we talk about what is the clinical status, what kind of a clinical symptom the patient has, whether the patient is in NH class 3 or 4, whether the patient has evidence of pulmonary arterial hypertension or some kind of right to left shunt, what is the LV function, what kind of a aortic disease the patient has. All these things have been given a scoring system. More than 4 points talks about higher mortality and morbidity. lesser the points, lesser the mortality. And this is the way all this scoring system has been put into as a modified WHO, CARPEG or ZARA. You can see clearly higher the score, higher the chance of mortality and morbidity. Hence, it's very much essential to risk stratify a patient and counsel a patient, especially when they have a high-risk cardiac lesion. What are high-risk cardiac lesion? When you go through this slide, you clearly see a lady with Heisenberg syndrome or a severe pulmonary arterial hypertension, prior periparietal cardiomyopathy with reduced LV function, or severe hereditary thoracic aortopathy, especially Marfan's with aorta more than 45 millimeters, Bellal annulus, bicuspid with more than 50 millimeter, and few other high-risk conditions like severe aortic stenosis or mitral stenosis, LV function is less than 30%, Fontaine procedure with arrhythmia, LV dysfunction, or coronary artery dissection. These comes under high-risk cardiac lesion. Few of them can be rectified. Like, for example, severe mitral stenosis can be rectified by doing a simple procedure called as a balloon mitral valvotomy. If you can rectify this and bring down the risk of an individual, that is always advised. If you can't rectify, especially like Eisenmenger syndrome, it is better to counsel them against pregnancy. Hence, it's very much essential to understand what are the high risk and what are the ladies who has to be counseled against conceiving. And what happened to neonates or offsprings? Depending on the maternal condition, whether the patient, the lady has a uncorrectable conditions which can go into obstructive, left side obstructive kind of a structure abnormality, or the patient is in class 3 or class 4, or a lady has severe LV dysfunction, or in spite of optimal medical treatment, the patient is desaturating. Even then, we have to advise them against pregnancy or conceiving. The basic reason is these uncorrectable conditions can have very high maternal as well as neonatal mortality. Whenever there's a possibility of correcting, either by medications or by intervention, it has to be addressed and rectified so that the risk for the mother and the baby will be brought back to as minimal as possible. If not correctable, then we have to advise against conceiving. As my previous speaker told, it's a teamwork. There are multiple stages involved. We have to identify the lady, whether the lady has some kind of a genetic abnormality, because this can be passed on to their offsprings. Hence, it's very much essential to identify whether the lady is suffering from any kind of a genetic condition, like it can be arteriopathy, it can be as simple as a bicuspid aortic valve. These individuals has to be screened for genetic abnormalities so that we can counsel them what is the chance of their offspring developing similar kind of a disease, and is it safe to go through pregnancy and delivery? Are there any chance of developing complication? How to manage them? That's very much essential. Few conditions can have very minimal chance of inheritance. It can be a 0.5 to 2%. Few conditions like Marfan can have higher chance of inheritance. Hence, it is very, very essential to understand, counsel the family. As you were discussing in this discussion and the previous discussion, this is a multidisciplinary approach. It's a pregnancy heart team with a family discussion, which should include cardiologist, maternal fetal medicine specialist, obstetricians, anesthetists, nursing staff, and the lady and their family. Basic goal is to provide preconception counseling, coordinate pregnancy and surveillance, anticipate and treat complications, develop and disseminate delivery plans, and ensure appropriate postpartum follow-up. The frequency of surveillance when a pregnancy is based on the severity of the cardiac lesion and the possible maternal and fetal risk and what time this kind of a complication may develop. Like some condition can worsen later trimester, some can worsen a mid trimester. Depending on that, we need to image and follow up these patients. And what about imaging? See, there are a lot of myths regarding imaging. A lot of people feel if you do ultrasound or echo or some kind of a vast invasive procedure, it can harm the baby in utero. Amongst the investigations when you suspect a cardiac disease, the safest is ECG. It does not harm either the mother or the baby and gives good amount of information regarding either congenital heart disease or acquired heart disease or arrhythmia or kind of a heart pumping capacity. But it has to be confirmed by various other modalities. Echo is the next modality which is commonly used worldwide and also safest. It can be done at even the peripheries. Usually what we do is a transthoracic echocardiography. Sometimes this imaging may not be sufficient. We may have to go ahead with transesophageal echocardiography. It is relatively safe. But we have to monitor the fetal heart rate. Sometimes what happens, it can induce various reflexes and the baby or the mother can go into bradycardia or can aspirate. Hence, transthoracic echocardiography is the safest. We have imaging heart. TE is not contraindicated. In specific conditions, you may require TE in addition to transthoracic echocardiography. Beyond this, in specific conditions, especially like mild to moderate mitral stenosis or aortic stenosis, you may have to assess the exercise tolerance. You may have to do a treadmill test. It is safe. You have to assess the individual, whether the lady is anemic or any other related contraindication for exertion. If indicated, then only we should subject the individual for exercise testing. Treadmill is the safest. In other conditions, we do other stress tests like Dobitman stress test and other pharmaceutical stress test, but in pregnancy, it's contraindicated. It should be avoided. Next set of investigations is chest X-ray and CT angiography. It is usually contraindicated because of radiation exposure. However, the radiation exposure is not very high. In conditions like aortic pathology, where we may anticipate an impending rupture, it can be life-saving, or we suspect a pulmonary embolism. Then the benefit outweigh the risk. Hence, CT can be safely done using a lead shield for the abdomen. In these two conditions, should not hesitate to do a CT. But in other conditions, we have other imaging modalities which can give us sufficient information where we can avoid our radiation exposure to the individual by using those modalities. And about cardiac catheterization, previous speaker talked about cardiac catheterization. With the present advances in imaging modality, especially echocardiography, hardly any patient requires cardiac catheterization in pregnancy, except for a therapeutic procedure. Like we want to do a bell mitral valvolectomy, it is a therapeutic. Then only we do catheterization. Otherwise, usually we don't do catheterization. It's not required. We have sufficient advances in echocardiography, which can give us all kind of information about the pulmonary pressures, LV function, RE function, structural imaging, everything we can make out on echocardiography. Sometimes rarely, you may require an MRI in addition to echocardiography to identify structural abnormalities, but it's quite rare, but it can be safely done in a pregnant lady. Till now, I went through general condition. We'll go through specific conditions. I don't want to go in detail. I just take up few conditions which is very much essential and which are more of a risk factor for a given lady. Most important and common is pulmonary arterial hypertension. It can be because of congenital heart disease, or it can be because of irreversible non-cardiac conditions. This pulmonary arterial hypertension is significant and is not reversible by medications or some other means. We need to recommend against pregnancy. By chance, if a lady becomes pregnant, then transthoracic echo is sufficient to give us sufficient information regarding the severity of pulmonary arterial hypertension and following up also. Why it is of high risk? We can have a significant high both maternal and fetal mortality if an individual has significant pulmonary hypertension. Hence, in a severe PH patient, if not treatable, we need to avoid pregnancy. And next is Eisenmenger syndrome. This is also a condition where the individual has significant pulmonary hypertension causing right-left shunting. If these individuals become pregnant, systemic vasodilatation can increase or worsen right-left shunting and decrease pulmonary flow, cause worsening of symptoms. Transthoracic echo is sufficient enough to diagnose, assess these patients. This condition also has a very high maternal and fetal mortality. Hence, better to advise against pregnancy. But the problem with this condition is of severe pulmonary hypertension. By chance they become pregnant, either accidentally or intentionally, even medical termination of pregnancy also carries a high risk. And even if they want to continue, there may be a high chance of miscarriage in these individuals. Hence, it's better to counsel against pregnancy rather than to have higher maternal and fetal mortality. And there are other conditions like atrial septal defect. These are hardly any contraindication, and majority they sail through uneventfully. But few things has to be considered. In unrepaired, there's a minor chance of thromboembolic complication because of right-left shunt, because you can give some IV injectables or some during delivery also they can have some kind of right-left shunt. Rarely they can have a thromboembolic phenomenon. And one more problem with these set of individuals, especially if they are of advanced stages, arrhythmias. Lot of AST, either unrepaired or repaired at a later age, can develop arrhythmias. It can be in the form of atrial arrhythmia or ventricular arrhythmia. This can really give a pain to treat this patient, but majority of these arrhythmias can be treated safely with medications. There are a lot of drugs nowadays to give in these individuals safely without any side effects and can be safely treated. However, if required, we can do procedure, but hardly they require any kind of a intervention during pregnancy because AST is safe during pregnancy. And next common condition is a VST. Unless large with LV dysfunction, they tolerate well. But if it's a large VST, they have a higher risk of arrhythmias and heart failure. Once again, once a diagnosis of pregnant, once we want to confirm when the pregnancy is confirmed, we have to do a transthoracic echo. Depending on the significance of shunt, LV function, or any other complication, the frequency of repeating the echo has to be decided. But majority of these individuals tolerate pregnancy well and they sail through. And conditions like AVST, TOF, majority of these individuals safely sail through, and transthoracic echo is sufficient enough to give sufficient information about the diagnosis and the complications. Even Epstein's anomaly also, people can stay safely sail through. But one thing what should consider is, in Epstein's anomaly, there are higher chance of developing arrhythmias that has to be assessed. You take a ECG to see whether the patient has a auxiliary pathway. If so, the lady may require drugs like beta blockers or some other drugs. If you can identify these individuals pre-pregnancy about these chance of arrhythmias, we can rectify the arrhythmia by doing a RF ablation so that they can sail through pregnancy without any kind of arrhythmias in the later day. When you move to complex congenital heart disease like TGA, another complex like a DORV, few of these conditions require either palliative shunt or complete repair. Ultimately depends on what is the morphology of the ventricle, how good the ventricle size is the left ventricle, right ventricle function is normal or not. Has a patient repaired the very early age? What is the functional capacity of the individual? All these things matter for the outcome. The individual has just a palliative shunt in WHO class 4 or 5 as a LV or RV dysfunction or a chance of development of arrhythmias. There's a high probability that these ladies can go into heart failure or can throw some arrhythmias and can have higher fetal and maternal mortality. To diagnose, transverse echo is sufficient enough. Even for follow-up or to identify the complication, that is sufficient enough. There's no need to go ahead with any other investigation in addition to transverse echo. With the advancement of age, with the ladies with congenital surviving pregnant age group, when a frontal circulation patients can reach this age, but however, these people can have multiple complications. They become pregnant. It can be prothrombotic, or can have a bleeding kind of a risk. They can have miscarriage. They can have platelet dysfunction. Ideally, I induce frontal circulation. We should not recommend pregnancy. But if a lady become pregnant, then we have to anticipate all these problems, and we have to treat accordingly. And conditions like coarctation of aorta, if we know it pregnant level, it can be rectified completely, either by a percutaneous intervention or a surgery. Post-procedure, they can become pregnant safely unless it's a part of aortopathy. By chance, they become pregnant, then we come to know she has a coarctation. It's very, very important to monitor the blood pressure level. You have to check both upper and lower limb blood pressure. You should not allow lower limb blood pressure to go below 100 systolic, because what happens is the upper limb will be pseudo high. If you chase upper limb blood pressure, fetal perfusion may not be sufficient enough, and you can have either high UGR or a miscarriage. If the lady has refractory hypertension, then we can do intervention and rectify coarctation even in a pregnancy. But however, there is a possibility that you can have some kind of complication or you can lose the child. Hence, it's always better to treat them at a pre-pregnancy level so that their pregnancy will be smooth. It is a small chart. Depending on the type of congenital heart disease, there is a significant amount of obstetric risk and a fetal risk. And a lot of congenital conditions can be because of genetic problems, which has to be screened so that we can advise them, counsel them about the risk for the lady as well as their offspring. Next, coming to valvular heart disease. A few more slides because it's very, very important. And we commonly see these individuals, especially of mitral stenosis or aortic valve pathology, most common condition which causes problem in pregnancy is mitral stenosis. any left side obstructed lesion can worsen or precipitate in pregnancy because of changes in the hemodynamic parameters which happen in the lady. If mitral stenosis is mild, it's well tolerated. But if it's moderate to severe, we should anticipate complications, especially in the form of heart failure. And some people can have arrhythmias, especially atrial fibrillation. And we should, a lady of known mitral stenosis has to be evaluated for the severity, accompanying arrhythmias. They have to be counseled, advised, depending on the possible preconception procedure, or if by chance, if it's not required, then what will be the course and how it has to follow up. Because left side obstructive lesions can have significant both maternal and fetal risk. The lady can go into heart failure, or we can have premature delivery or IUGR in the fetus if it's untreated. Hence, follow-up is very much essential. Because of a physiological hypervolemia, there will be increasing gradient, which can increase obstruction, causing worsening of the primary pathology. And especially, lady with significant mitral stenosis can have heart failure during labor because of a shifts in fluid, which happens during uterine contraction. Hence, significant mitral stenosis has to be addressed pre-delivery. It should not be left untreated if diagnosed. And these people can have chance of arrhythmias, especially atrial fibrillation, or can develop a LA appendage clot if they have arrhythmias. Hence, all these things has to be considered and treated accordingly. How to assess these patients? When you know a lady has mitral stenosis, before the planned pregnancy, they have to be evaluated. If it's a mild, medical treatment is sufficient enough. If it's moderate to severe, we have to assess the clinical status. If a lady is asymptomatic, then we have to subject them for exercise testing, assess pulmonary arterial pressure. If the pulmonary arterial pressure goes beyond 50 mm of mercury after exertion, in an asymptomatic patient of moderate to severe mitral stenosis, these ladies require intervention pre-pregnancy. Intervention, usually it will be a simple procedure like a balloon mitral valvotomy. Sometimes if the valve is not suitable, they may require something beyond, which has to be surgical. Any symptomatic moderate to severe MS, planning pregnancy has to be operated by balloon mitral valvotomy if valve muffle is suitable. Hence, it's very much essential to treat this individual at a pre-pregnancy phase itself. And how to follow up? If it's a mild mitral stenosis, one visit 3 months is sufficient. If it's moderate to severe, either monthly or bi-monthly required. When to do echocardiography, first antepartum visit, then third trimester. And one important thing, what has to be seen on echo is, we have to measure the orifice, because mitral gradient, pulmonary artery pressures may increase as a pregnancy progresses. Hence, all these factors make a difference when we assess an individual, and an individual of symptomatic moderate to severe MS has to be addressed before they conceive. Next most important valvular lesion is hiatic stenosis. Any left side obstructive lesion, if significant or symptomatic, can cause problem. Same thing with hiatic stenosis. If it's a mild degree, it can be left untreated. If it's a moderate to severe AS, it has to be addressed, because otherwise it can cause complication in both for the lady as well as the fetus. Hence, in a patient of hiatic stenosis, severe to hiatic stenosis, exercise capability, the lady is in energy class 2 to class 4, or LV dysfunction, or increasing PA pressure on excess test. These ladies has to be counseled against pregnancy, and this problem has to be rectified, then only they have to plan pregnancy. But if a significant AS patient is asymptomatic, PA pressure does not increase on exertion, LV function, LV size is normal, excess tolerance is good, then we should not discourage pregnancy in a patient of significant hyperstenosis.
Excuse me, sir, Dr. Santosh, sorry for interrupting. I think a gentle reminder for the time, sir. We have one more speaker.
Yeah, almost I've done. Okay. 2 more slides.
Yeah, I just thought I'll remind you. Thank you.
Yeah, fine. Thanks. Thank you. I think when you plan a prosthetic wall in a patient who contemplate pregnancy, it has to be a bioprosthetic wall because higher chance of thrombotic events, and we have to use oral anticoagulants with mechanical walls. And we have, because of increasing age of pregnancy, I think coronary artery disease, peripheral cardiomyopathy, all these things, all these diseases has come up in a bigger way in these ladies. This has to be assessed, treated accordingly. Hypertrophic cardiomyopathy, other cardiomyopathies also has to be assessed. Aortopathy is one of the most important thing. The most significant factor is size of the aorta here. The ascending aorta size is more than 45 millimeter. That is against conceiving, or it has to be addressed pre-pregnancy, so that once you rectify the problem, you can advise pregnancy if it's not a inherited disease. Otherwise, that is against conceiving. And majority of times, you have to either go with the cesarean section or cut short the second stage of labor in aortopathies. To conclude, all women with known cardiac or artery disease who wish to embark on pregnancy require timely pre-pregnancy counseling. Most important factors are functional, clinical symptoms. LV function and PA pressures on echo plays a bigger role. Other aspects must be discussed: long-term prognosis, fertility and miscarriage rates, risk of recurrence of congenital heart disease, initial and follow-up imaging, drug therapy, estimated maternal risk and outcome, expected fetal outcomes, and plans for pregnancy care and delivery, depending on the individual disease the lady harbor. Ultimately, the multidisciplinary management plan should be constructed for a given patient and discussed with the family and to be advised and followed. Thank you. Thank you for.
Thank you, Dr. Santosh. It was a very informative and an exhaustive lecture. Definitely all our postgraduate students have been very much benefited by your talk. Sir, I just have a basic question for the practicing obstetricians. What is your call on SP prophylaxis?
Sorry? Hello?
Yes, sir. Subacute bacterial endocarditis prophylaxis, sir.
See, nowadays, except few conditions, majority of condition does not require a high prophylaxis. Complex congenital disease, especially cyanotic, prosthetic heart wall, requires prophylaxis. Otherwise, you can follow whatever antibiotic protocol our individual hospital has. Nowadays, because of an increase in hygiene, hardly majority of the cardiac condition does not require prophylaxis, and majority of prophylaxis will be oral nowadays.
Okay, sir. Thank you, sir. Thank you very much.
Thank you, Dr. Santosh. We have one more question in the chat for you. The question says, like a pregnancy with the cardiac stenting. So how a obstetric practice should be approached? We have a question in the chat.
See, pregnant lady with a stent, there's no difference in the only thing is this page. These are the patients who have a ischemic heart disease. Because pregnancy itself is a prothrombotic milieu. Pregnancy itself is a prothrombotic milieu. They require antiplatelets, statins, like conventional ischemic heart disease patient. Whether the stenting is because of a atherosclerotic makes a difference. For example, the patient has a that can recur in a pregnancy, and it cause acute coronary syndrome. Because stenting we usually do for atherosclerotic heart disease, not for a spontaneous coronary artery dissection. And it's very-
IHT will be discussed in detail in the third webinar, sir.
Okay.
We will be discussing all these things in detail.
The question was asked by some, that's why I was answering.
Yes.
Yeah, please.
Okay. It doesn't make any difference for a lady. They have to be given antiplatelet statins. And only thing what has to be assessed is whether it's a sudden spontaneous coronary artery dissection causing ACS or not. If that is the case, there's a possibility that it can recur in this present pregnancy. Previous angiogram report or imaging will give us information whether the patient harbors a chance of developing spontaneous coronary artery dissection or not.
Thank you, Dr. Santosh, for the vast information. To summarize, very importantly, in any suspected car disease, the pre-pregnancy evaluation of cardiac status is mandatory with a cardiologist and a proper cardiology echo, and it should be a multidisciplinary management. Thank you so much. We'll move on to the next talk by Dr. Deepa Bhatt. She is a professor of anatomy and at the Jesus Medical College, and she is doing a lot of research on the genetics with related to the obstetrics, and she is here to enlighten us on the topic of genetic counseling in women with heart disease. Over to you, Dr. Deepa.
Good morning. At the outset, I would like to thank SMFMI and also the OBG, JSS Medical College and Hospital Mysuru for giving me this opportunity to be a part of this renowned community of cardiologists as well as obstetricians. So I would be sharing my screen. So I'm a level 2 genetic counselor working since 7 years as a genetic counselor at hospital. So before beginning, like what is a genetic counselor? Maybe currently we are experiencing the global warming. A genetic counselor is like an air conditioning. When you don't have it, you don't realize you are missing it. But when you have it, you can't live without it. So I think in future presentations of whichever is a community, in the comprehensive community, I wish the genetic team should also be incorporated so that we are in the era of precision medicine now. So as a counselor, it's not the patient or a woman we deal with, it's a family referred to us for evaluation of a possible genetic condition. So there is an interpretation. We offer pre-test, post-test counseling, education, and also a comprehensive care, including a psychological support and to live with a disease with a better quality of life. So why should we really have a genetic counseling for the women? So many times we have been referred with the history of infertility where we have found there is a possible genetic cardiac genetic condition and recurrent pregnancy loss or bad obstetric history. And why should we really worry about is if a lady with a genetic condition conceives, then what are the maternal implications add on to her own cardiac hemodynamic status related to this particular genetic condition, as well as the concern of the family on what is a heritability. Because the recurrence risk depends on the pattern of inheritance. Though most of the cardiac genetic disorders are autosomal dominant, there are certain conditions which are recessive also, and there are X-linked and even mitochondrial. Because if a lady is having a mitochondrial disorder, then each one of her pregnancy would be affected and her own status of the cardiac condition. If it is the recurrence risk, autosomal dominant means 50% recurrent risk, recessive would be 25% chance. So let's go one by one. So why is it? In addition, as I said, previous speakers also mentioned, the physiological adaptations happen during pregnancy. And the very important thing is, though they are having the disease nowadays, because of the very good clinical care, we have the women who reach up to the marriageable age, they plan to conceive or they would come to us once they are pregnant. So there are chances that many of these cardiovascular disorders become unmasked during this particular period or peripartum phase. And already they have physiological adaptation. there would be a cardiac decompensation during the pregnancy because there would be some genetic disorder which surfaces out during the pregnancy. So counseling, testing, and taking a complete family details will help them to identify what is running in the family and proactively manage such a cardiovascular risk. So what all we should worry? Specifically to Mysuru community, it's 40%. We are second highest in entire India in terms of consanguinity. So 40% of the females referred would have consanguinity. And the word of caution for the residents is that when we take a pedigree, because of the workload, we happen to take only parents. So 3-generation extended family details most of the time will give us a detailed pedigree itself sometimes is a very good indicator of suspicion. So we have certain situations where we happen to look only the woman who is referred to either cardiologist, we look at the heart, or an obstetrician will look at a female from the point of the fertility or her OBG conditions. But we have to comprehensively, entire as a whole, they have to observe many times just a preauricular tag or a subtle dysmorphic features would indicate a webbed neck, increased carrying angle, or outturned ears. So these are some of the very, very subtle features which may not be noticed at all. So they indicate some of the syndromes. Some other clinical manifestations like associated skeletal dysplasias, muscular dystrophies, or sometimes even the sensory neural deafness, which we usually think that it will not be inherited, but per se, for example, Jervell-Nielsen syndrome, here sensory neural deafness may have arrhythmias. So these are the things which we really have to. So the message here is not only from obstetric point of view, look for possible dysmorphic feature, consider a 3 extended pedigree, that is a family history, and also other clinical manifestations. So why we should? Because patient with cardiac phenotype, we will help them to diagnose what is the cause of the disease. And during genetic counseling, we will offer them the genetic testing. And the genetic testing are multiple. There is a wrong notion that just a karyotyping itself is sufficient to get the complete diagnosis. And it will also help us to give the prognosis regarding their particular genotype. And also it may sometimes change their management options. And also what are the triggers which can manifest their disease clinical manifestation, and also help in cascade testing, extended family testing, and reproductive planning. Now coming to specific test. So as I mentioned, every time there is a wrong notion, because I get during the clinical practice, when I offer some of the genetic testing, I think most of you are aware that there is a range of testing starting from 1,500 rupees up to 75,000. So when we offer them the test, they are ready to accept. But when we explain them the financial component, most of them will be really, they take aback because will I be able to afford this? And second thing is because they spend a lot of time with their primary physician, that is the obstetrician, if we offer an additional genetic testing, like they would have already done karyotyping at the obstetrician, when we offer an additional testing, most of the time they say that it's already done. Why are you asking us to get more tests done? So some of the examples here are, so the Turner syndrome. So Turner syndrome, the classic case sometimes may have a streaky ovaries and there is a incomplete development of reproductive organs, but we encounter many of the times a mosaicism. So the trisomies also, if there is a mosaicism, then there are chances that there could be a milder phenotype where a female reaches up to the puberty or even further and come for planning the pregnancy, which can have associated cardiac condition. Now next would be the karyotyping has a limit. Anything chromosomal aberration more than 5 MB change alone can be detected by karyotyping. If it is less than 5 MB, definitely there is a disease, but this particular test which is chosen is not sufficient to diagnose. So next advanced testing is we have something called as chromosomal microarray. Here, anything up to 100 kb can be detected. So when do we usually go for it? There is dysmorphic feature or a combination of anomalies. Along with the heart, there is some kidney finding or there is some skeletal finding and there is no consanguinity. The first choice would be, other than karyotyping, is a microarray. Nowadays, ICMG has almost ruled out karyotyping, but they directly go for microarray. But in Indian context, because of the cost involved, we start with karyotyping and then offer microarray. The next would be the target gene sequencing. You can see. So we already have a criteria and we have diagnosed it as a Marfan syndrome. A very clear-cut major criteria, minor criteria says us it is Marfan. Then we can go for a target gene where I know this is FBN1 gene and this is itself will be tested. So that is called as target gene sequencing, which will drastically cut the cost of our testing. Now, next would be the clinical exome. When will we offer clinical exome is that there is a condition like the HCM, hypertrophic cardiomyopathy or dilated cardiomyopathy. Many genes are involved, more than 19, 20 genes are there. I don't know which is a gene, but I'm very clear about the clinical finding. That is, it is only DCM. Then we will offer them the clinical exome and finally come to the diagnosis. Yes, this is a particular gene. This is a particular exon. Is it a loss of function or gain of function? Is it a missense variant, nonsense? Based on that, the severity may vary. A missense may be a milder variant, many times a splice site or a promoter region, or even the nonsense may become very severe clinical. It also helps us to indicate the severity of the disease. Coming to the next test is a whole exome sequencing. Now we have combination, very unclear. So along with the cardiac, there are vague symptoms not specifically fitting into one syndrome. Then we go for a whole exome. Now with the current utility, the clinical exome and whole exome doesn't have much price difference. So the whole exome also covers some of the intronic variants. So to say here, exome is a one which gets translated into a protein. Intron is not translated. But however, if there is a very big change in the intron, then it will frame shift leading to a altered reading frame sequence, thus the protein product. So in such cases, if you are really in doubt, go for a whole exome. Now, already somebody is done with the genetic investigation in the family. I want to test only the extended family members. Then you need not go for all these tests. You can directly go for something called as Sanger sequencing, which comes in hardly 2,500. So that will confirm by the whether this particular mutation is present in other person or not. So as I said, not everything is a Mendelian. There could be chromosomal aberration, as I've shown here. T8, T13 trisomies can have AVST, TOF, TGA. So all this, if they're very severe, we don't see them surviving their 5 years or even 10 years. But some of them, because of the milder variants, or if they are mosaic, then they have an extended lifespan. Now, microarrays which detect the CNVs, like you can see DiGeorge syndrome, then it can be a duplication. Many times duplications have a milder phenotype and deletions will have a severe phenotype. So the bracket indicates an associated cardiac manifestation, Wolff-Hirschhorn syndrome. Coming to monogenic, Charge, Coffin series, Ellis-Van Creveld, all these have a specific facial feature or of specific features which indicates that yes, this is a disease. Then we can go for a target gene or a clinical exome sequencing. Now focus, there are genes which are associated with CHDs. So the list is very big. I have few mentioned here. So they are, why this is important is that the woman who has come to you may have these. So managing her condition itself is per se is important. And her next question would be, can she become pregnant? Can she sail through her 9 months of pregnancy? What is an additional care as a combination of obstetrician and a cardiologist is required here, as well as what are her chances of carrying it for the baby? So these all will come into picture when depending on what is the type of the condition. Apart from that, now we have reached an advanced stage where the above first 4 can be detected by routine genetic testing. The last one is multifactorial. We have been hearing a lot of
early death in 40s because of the coronary artery disease. Now we have come up with something called as polygenic risk score, where a combination of algorithms are used to say are you at a medium or a high risk or a mild risk based on the multiple members in the family who had a early sudden cardiac death. These also there, but multifactorial, we give a guarded, like not all the tests are available for every gene, but we could to some extent help them with the diagnosis. So what are those common Mendelian? So we very commonly we come across cardiac channelopathies like Brugada syndrome, long QT, short QT. Then HCM, there could be familial HCM, Noonan syndrome, rasopathies, glycogen storage 2 and 3. Then DCMs like the Emery-Dreifuss muscular dystrophy. LGMDs are very, very common in and around Mysuru. So every month, 1 or 2 LGMDs are diagnosed. Friedreich's ataxia. Then those who primarily present with arrhythmias. Then there is even severe dyslipidemia, the familial hypercholesterolemia. We have seen the case of cytosterolemia. The cytosterolemia has a disadvantage because the routine, the lipid profile we do comes normal, but it is a plant phytosterol, which we do not have any measuring component. So this, they present with organomegaly, hepatosplenomegaly or bone marrow suppression. So this also has to be considered. Familial hypertriglyceridemia, and many almost 19 genes are implicated in familial iotopathies, and 11 of them has high penetrance. What is it? So as I mentioned, in autosomal dominant is the most common among all the cardiac genetic disorder. Here we need to consider two things. One is penetrance. Second one is the variable expressivity. What is penetrance is, we usually miss the history when they would have seen that my father is fine, but I have the disease. Here the other normal gene usually might protect, so they may not manifest, or it is so less severe that or milder that it may not get unnoticed. When it comes to next generation, it suddenly may appear. So the penetrance may be 10 to 100%, which will in turn determine how much is phenotypically expressed in an individual. Coming to variable expressivity, same gene can manifest only in heart. The Marfans, I'll give you a clinical example how this variable expressivity is observed. So the case which came to me where the primary proband who was referred was for the lens dislocation. So lens dislocation, he did not have much of the features. It was a 4-year-old boy. So when the pedigree was charted out, we found that his father was operated for aortic dissection. So later we had his sister who came to us seeking genetic counseling. So now usually the best way to diagnose is to start with the affected. So we did the boy who was primarily having dislocation. You can observe here, there is FBN1 Marfan lipodystrophy syndrome is there. So now we tested the woman, and she was also harboring, but at that time she was asymptomatic. So considering her brother having aortic dissection, this particular component was explained to her as well as the primary obstetrician, so that she will be closely monitored for aortic dissection and monitored through the pregnancy. So you can see that there is a likely pathogenic variant manifesting with the different. So the boy presented first with the lens dislocation, father presented with aortic dissection, and sister who came with pregnancy was not manifesting anything, but she was harboring the mutation. Another case where a 26-year-old female, she was referred because she was having multiple contractures. When the clinical examination was done, the observation was there was multiple calf atrophy was there, and multiple and proximal muscle weakness was there. Contracture of feet was observed. Along with that, there was hirsudism and PCOD. Her primary referral was for inability to conceive. But when the history was asked, she was born out of consanguinity. And in the pedigree, her younger sibling had succumbed to a cardiac cause. They said it was a sudden cardiac death. at the age of 14 years, which was not detected or clinically was diagnosed. And also there was a history that father also died with similar history at 36. So you can see that the female who was a primary person who visited me had a muscle findings, but the father and the brother had a cardiac finding. So when we did the testing of the female who came to us, she had LMNA exon 10. There was a mutation, autosomal dominant, which is pathogenic. So you can see that the Emery Rufus muscular dystrophy was diagnosed. Now we discussed. So the first thing is we had to make her understand that she could also manifest cardiac symptoms somewhere during pregnancy with so much of contracture. She even had a kyphoscoliosis. So will she be able to have a normal progression, third trimester complications physically also has to be considered. But with their mental status, having she only becoming pregnant for her extended family was a priority. So we had to balance whether will she be able to have a pregnancy, continued, have a normal outcome was on one side, and explaining the family on the psychosocial implication was additional challenge which we faced. So you can see that this particular LMNA is having cardiac conduction defect could be the answer for the sudden death of her sibling as well as a father. The last case is that primarily this female was referred to me for PCOD, hypothyroid and planning pregnancy because there was a history of infertility. So that is on one side. So all the regular tests like the basic usually referral to genetic is after ruling out the hormonal causes, autoimmune causes or infection, then they would be referred. All these were normal. But with this when many of the time it happens that when the childhood histories are not revealed at all. So after multiple probing, she revealed that when she was 10-year-old, she had a PSVT ablation surgery. So that gave us a little indication. So there is a possibility of some condition which may be genetically present in her. So we went for a exome sequencing. So RMB20 dilated DCM1 autosomal dominant, which is associated with arrhythmias, was observed. So with this history, we usually refer them back to cardiologist and further to keep all these things into consideration, as well as parallelly evaluate her infertility as well as the cardiac condition here. So just to summarize here, the heart disease, you can observe what I want to take home message. It's ischemic, non-ischemic with abnormal structure, non-ischemic with normal structure. These are the very common manifestation which are routinely encountered in the clinical practice. So always a high index of suspicion. As we all know that eyes do not see if the mind doesn't consider at all. So have a genetic etiology also in your differential so that you won't leave anything in your final diagnosis of the person who has visited you. So a word of caution, the last as a genetic counselor, nowadays the primary physician directly offering the genetic test is very commonly practiced now. But the challenge is that number one, timing. Usually when the lady is pregnant in her 14 to 18 weeks, they undergo genetic testing. If the report comes as variant of unknown significance, which is commonly, that means this is not known to a genetic community till now, whether is it really causing the disease or not, then interpretation will be very difficult. So always go for a preconceptional or work with the genetic team so that the phenotype-genotype correlation, then segregation analysis. So all these will be together will avoid, because I have had a situation where a wrong interpretation of a carrier status as affected led to termination of the pregnancy, or even the variant was present in the fetus, but when we did the parental testing, that variant was present in the mother who was asymptomatic. So that itself says that this variant is not going to harm. So I would like to end my session saying that though genetic is very much useful, the right way of interpreting and will only benefit the family. So with this, my key message from this session is high index of suspicion, please do consider the genetic team also into your the comprehensive care team, and always plan ahead so that the ultimate benefit for the patient or the family who visits you will be delivered. Thank you.
Thank you, Dr. Deepa. Indeed, it was a great mind-blowing sessions, and you open our thoughts into the genetic aspect of the cardiac disease. Of course, nowadays, all the obstetricians and fetal medicine, we are always managing with the team. And of course, the genetic counseling and the role of a genetic counselor is also very important, especially when we are dealing with the familial disorders. Thanks for the input. And in the first session, we have an exhaustive and very elaborative discussions on the cardiac disorders. Now we'll have move on to the panel discussions, which will directly lead us to the case-based discussions. Over to you, Dr. Hema Priya, to take over the next session.
Thank you, Dr. Sushma and Dr. Mamta ma'am for chairing the session, and also to all the speakers for enlightening us and having an exhaustive discussion. We will now move ahead to the panel discussion. Although we are running short of time, we will still have the panel discussion. So I would like to introduce our moderator, Dr. Nagaraj Desai. Sir is no stranger to JSS. He was the former HOD at JSS over a period of 10 years. And he has always taken a keen interest in cardio-obstetrics. So along with introducing Sir, I would like to invite our experts for the panel today, Dr. Malini. We have already introduced her. Madam is a consultant obstetrician at Fernandez Hospital, Hyderabad. And joining her would be Dr. Sunanda, Associate Professor and Unit Chief at Mysuru Medical College. Now I would like to introduce our panelists. So the panelists are Dr. Srimati Raman from Rangadore Memorial Hospital in Bangalore. Madam is an FRCOG and an examiner for MRCOG and has various gold medals and publications to her credit. Joining her in the panel is Dr. Anu Joseph, again a fellow in fetal medicine as well as a consultant obstetrician at Kaveri Hospital in Bangalore, and she is one of the members of the Society of Maternal and Fetal Medicine. We have Dr. Praveen, a fetal medicine consultant at Mysuru at Navya Fetal Medicine Center. He's also has done his advanced fetal medicine training from the Royal College and gives excellent inputs in women where we have doubts whether to continue or to terminate pregnancy. So Sir always does a very good counseling for all our patients. We have from the cardiology side, we have Dr. Srinidhi Hegde, who's an assistant professor of cardiology at Sri Jayadeva Institute and is actively involved in many community projects and research. And joining him would be Dr. Nikhil Basavanagowda. Again, he is also an assistant professor at Sri Jayadeva Institute, and he has been the past EC member of the CSI Mysuru chapter and has various publications. I would now request Dr. Nagaraj Desai sir to take over the panel and continue from here.
Thank you, Dr.
Sir, you can share your screen.
Yeah. Thank you, Dr. Hema. In fact, we are very fortunate to have heard these three preceding lectures for us to make our panel discussion easier, simply because it may be some kind of a reiteration as to what have been discussed in the three previous brilliant lectures. Congratulations to all the three speakers. We have in the expertise area, Dr. Sunanda and Dr. Malini. And in the panel side, we have Dr. Srinidhi and Dr. Nikhil, good friends of mine, and also Dr. Anu and Srimati, as was introduced by Dr. Hema. In fact, this particular title, Case-Based Approach Management of Cardiac Diseases in Early Pregnancy, suggests that we should be discussing some cases wherein they are presenting to us where they are already pregnant, and we have to assess the mother as well as fetus. The presence of Dr. Anu and Dr. Srimati and also Dr. Praveen will come handy for us to understand what are their approaches in terms of evaluating such patients, such persons rather, mother and fetus. This has been already done. Now I have a lady, 24 years young, with a cardiac murmur. She's asymptomatic. Pregnancy confirmed 8 weeks earlier. Primary gravida, anxious and active professional that we commonly see nowadays. And a grade 2 systolic murmur in pulmonary area. I just wanted to request our Dr. Nikhil, in case he has any thoughts about this particular patient having a structural heart disease. What are his comments? Could you just join in and say a couple of words, Dr. Nikhil?
Yes, sir. Thank you, sir. Thank you, SMFMI Mysuru chapter, for having given me this opportunity. So the data that has been provided is grade 2 systolic murmur in the pulmonary area. So more often than not, as in pregnancy, there is increased cardiac output and there is increased plasma volume. There is increased flow across the pulmonary area. So most likely this will be a benign murmur. So what are the features that can raise suspicion is if there is an associated murmur along with it. I'd like to divide it into history as well as clinical examination. So in history, if the patient already has a cardiac disease, if the patient has any symptoms suggestive of cardiac illness, if the patient has had any event of heart failure in the past, or if the patient has had NYHA class 3 or class 4 symptoms, then definitely we have to further look into this murmur. In coming to clinical examination, if there is associated loud P2, if there is a parasternal heave, if there are features suggestive of cardiac enlargement, if there is an hyperdynamic apex, all these suggest that there could be an underlying structural heart disease. Of course, it goes without saying that if the patient has had cyanosis or if the patient has had any history of having a hole in the heart, that also goes more in favor of having a structural heart disease.
Would you like to leave this patient if there is no suspicion like this, or would you like to order some additional testing?
Definitely, I would like to further evaluate. So even if we have to label the murmur as being a Still's murmur or a benign murmur, we have to evaluate to rule out any underlying structural pathology before labeling them to be benign. So I'd like to get an EKG as well as an echocardiogram as baseline investigations, along with other blood investigations such as thyroid profile and complete hemogram, just to rule out anemia, sir.
Okay, wonderful. In fact, how do you quantitate this particular lesion if you find it to be an AST, for instance, by clinical evaluation and also by echo? Do you have any thoughts about it?
If the patient
also can do that.
Yes, sir. So if the patient has an ASD, the thing that I would look into is the pulmonary pressures. So if the pulmonary pressure is mild to moderate, then the patient usually tolerates pregnancy well and can continue pregnancy without any complications. If the patient has high pulmonary pressures, then it goes without saying that the complications rates are higher. It can be as high as 15 to 50% based on other studies. So the pulmonary pressures is the most determining factor regarding the outcome of pregnancy in patients with ASD.
Okay. Now, I wanted the obstetrician to jump in here to say that this patient has an 8-week pregnancy and she has a ASD and she also has a little higher pressures in the pulmonary circulation. What is their approach in case they have to counsel this particular subject and the family? Any one of them can jump in.
So it's Dr. Srimati here. Thank you for having me in the panel, and thanks SMFMI for giving me the opportunity. So I think as already spoken by Dr. Nikhil, I think the clinical symptoms would help us know. If she didn't have any symptoms under NYHA, because as was discussed, the risk classification becomes important here. So our NYHA are prior cardiac events, because all of these things would help us understand what is going to happen through the pregnancy. But if she is having raised pulmonary pressure, then depending upon the pressures, she might even come to WHO class 4. Because if it's only ASD, where the pressures are not higher, then she's going to be in the modified WHO class 2, where the chances of having a event is going to be maybe around 15-20% max. But then if it's going to be with raised pulmonary artery pressure, then it can even go up to 40 or even higher. So I think that is important. And of course, looking at a history in terms of a pre-cardiac event, and I would probably have an MTT discussion, because that's very important for us to understand what are we going to do, because pulmonary artery pressure could increase as the pregnancy advances. And because she's only 8 weeks, my options are much better now, rather than at 20 weeks where the pulmonary artery pressure becomes higher and then she becomes very symptomatic. Then I'm caught between the devil and the deep sea. Of course, fetal abnormalities also, because if it's ASD, there's a chance for the fetal inheritance. But more than the inheritance, I would be worried about the other complications because of the pulmonary artery hypertension, because ASD, simple ASD, or any of the other structural heart diseases, we may be able to pick it up on echo. And I would be worried about the pulmonary hypertension.
So wonderful. In fact, this particular patient, if he has only a mild pulmonary hypertension, or if the patient progresses and she comes in the second trimester, approach, will it be different from the obstetrician side?
Sir, it's a bit tricky because first trimester, maybe it's a bit easier even for termination if you're going to do. Whereas later on, again, because she's a young lady and the pulmonary hypertension is probably going to be only progressive. So with age and, with the progression of the lesion, it may not get better. So maybe I will have a realistic discussion, see where the pulmonary pressures are at. And if they're not too bad, maybe I would want to carry on with the pregnancy with an MDT approach and see whether we can optimize our cardiac condition. Because, in second trimester, termination is also going to be hard. And if she has sailed through so far and the pulmonary artery pressures are not very high, then maybe, I might be more inclined to, continue the pregnancy, provided the patient understands the risks involved and I have a good cardio-obstetric team.
Okay, now I wanted to ask cardiologist colleagues of ours, in case this patient has to be continued on pregnancy by the obstetricians and the patient's family desires, do you have any suggestions to manage this pulmonary hypertension, or do you think that you would rather wait and see? Dr. Nikhil and Dr. Nidhi?
Sir, thank you, sir, and thank you SMFMI for this opportunity. And as very neatly pointed by Dr. Nikhil, and now here, if we know the cause of the pulmonary hypertension, like as you mentioned, if it's ASD, we know it's a hyperkinetic pulmonary hypertension. So, and in pregnancy, it definitely will rise, but post-pregnancy, it will come down. So if it's in the mild range, around 40, and we know that it's hyperkinetic and we know the cause of it, so we can continue the pregnancy. And ideally, and we know the cause that it's primary pulmonary hypertension, and it will be higher risk.
So it is just a pulmonary hypertension that you have evaluated. It's not a hyperkinetic. There may be a suggestion of a pulmonary vascular.
That's what I like.
Do you would like
only?
Yeah.
Go ahead. Only this phosphodiesterase 5 inhibitors are indicated, sir, and prostaglandins are indicated in pregnancy. Other like endothelin receptor blockers are contraindicated in pregnancy. So we can offer phosphodiesterase 5 inhibitor therapy for them.
Fair. Okay, wonderful. In fact, I just wanted to bring in the discussion saying that not all is hunky-dory just because you find a grade 2 murmur. And indeed, some of the so-called minor defect or moderate defects can progress and can cause symptoms. So treat the patient as a whole and the family be included in that particular discussion. I have a second patient here. If you allow me to go ahead with the second patient, Mrs. LK, diagnosed for the first time, 20 years pregnant, 30 weeks gestation, presents with the rapidly progressive dyspnea with repeated orthopnea and PND. She has auscultatory features of severe mitral stenosis, requires relief and safe care, healthy outcomes for mother and yet to be born. What are your opinions, Dr. Srinidhi, for example? Is this heart failure difficult to diagnose in pregnancy always? if this patient were not to have orthopnea and PND?
Patient usually have this dyspnea because of the pregnancy pressure effect, but it's not that difficult, because if already she's 30 weeks gestation, if she had earlier symptoms, we should have evaluated her by doing an echo, and we would have diagnosed that. But here, the scenario, it is saying that it's already 30 weeks gestation and she is having symptoms of dyspnea. She's in pulmonary edema features. So that will be a higher risk. It's not difficult to diagnose heart failure in pregnancy, but initially it will be confusing in young patients, apprehensive patients. It will be confusing, but better to have a simple modality and very non-radiational modality, echocardiogram. So we can do that and we can diagnose it easily. And also we have biomarkers if we really suspect at NT-proBNP we can do. But here we can definitely, and by the history itself, we know that patient is having mild stenosis with pulmonary edema.
Fair enough. Now that you brought in that word radiation, what this patient should be planned for? What is your opinion, Dr. Srinidhi?
So because she's definitely we should to save her life and first importance is to save the patient, save the mother. So we should, I think, stabilize her with diuresis, and then we should, if the valve, look for the suitability of the valve, and if valve is suitable for PTMC, that is balloon mitral valvotomy, then we should take it. And because of the fluoroscopy and the radiation we use during the procedure, we should take the precautions, putting a guard, radiation lead apron onto the stomach, so that we can prevent some radiation to the fetus. And we should be little skillful enough to do the procedure as soon as possible, and little bail out that condition, like balloon at the mitral valve, so that there will be significant decrease in the preload, and afterload, decrease in the afterload also, and patient will be better.
Now let's listen to Dr. Nikhil also. Is there any difference of opinion between you and him? Dr. Nikhil, please.
Yes, sir. I think Dr. Srinidhi has told most of the things. Apart from that, you should also look into anticoagulation, because a patient has had severe mitral stenosis. They're at more risks for developing left atrial appendage clots and thromboembolic phenomena. So we should also look into presence of clots before going ahead with the procedure, sir.
Sure. Try and reduce radiation and using thoracic
yes,
and other issues. Thank you so much. In fact, let's listen to obstetricians. How do they perceive this particular patient in terms of management and involving cardiologists in this particular decision-making? Obstetricians, one of them, please go ahead and comment on this.
Definitely, we would be involving a cardiologist, and probably the first people that we would involve the moment they have PND and orthopnea. There's no doubt about it. And thankfully, you put that 20 weeks in the last one to 30 weeks now, which is a little more comfortable for us. Because at this point of time, like Dr. Srinidhi was saying, mother comes first. But at this point, we can also think about the baby first as well, because it's a very viable gestation in most of the good setting hospitals at this point of time. So if at all there is a confusion, the confusion is between treating the mother for a proper valvulotomy and etc. versus delivering the baby and then going ahead and doing the rest of the treatment for the mother. So that's where we would want a good discussion to happen between the family, the cardiologist and us, so that we can, and of course a neonatology team, to understand if we can just steroid for the baby for lung maturity, deliver the baby and then go ahead with the mother's treatment, or is it going to be the mother's treatment, wait a little while, stabilize the mother and then go for the delivery of the baby.
In case the obstetrician wants to deliver the child first, what are the cardiologist's concerns? Dr. Nikhil, do you kind of clearance or you kind of caution them severely?
I would definitely caution them, sir, because the patient has severe mitral stenosis and already the patient has had an episode of orthopnea and PND. So if the patient is taken for safe confinement, then the chances of the patient going into full-blown pulmonary edema is quite high, especially in the second stage of labor. So I would definitely recommend doing the percutaneous mitral commissurotomy first, followed by safe confinement, sir.
In fact, at this stage, I may point out there are several publications from India also published in all national and international journals regarding the use of balloon mitral valvotomy as a bailout procedure in patients who have presented into the ERs as an emergency mitral valvotomy and delivering the patients properly. That's very important consideration.
Sir, here I have a query, sir.
Sure,
So
go
if
ahead.
she's suitable for commissurotomy, then we are pretty okay with it because it's going to be anyway percutaneous procedure. The chances of risks for the mother or for the baby is going to be less. So we are going to take some adequate precautions. But what if she's not suitable for commissurotomy? Because if you're going to do an open valve procedure, because if there is going to be severe valve disease, then it becomes a very tricky situation. So maybe if we want to stabilize the mother and then deliver and then plan for the mitral valve procedure, because if it's a commissurotomy, it's pretty okay. But then if it's going to be an open heart procedure, I'm going to be a bit, sort of worried.
Now let's listen to the experts, like the cardiologists again. How do you want to stabilize this patient while they are delivering this particular child? Do you have any suggestions for the obstetricians?
And at 30 weeks, inducing and delivering vaginally may not be everybody's option, definitely. So second stage,
It will be difficult as well. Yeah, I think she would have to have a C-section only because 30 weeks, even if she stabilizes when she's had an heart failure, that would be one of the indications for section. So Dr. Nikhil or Dr. Srinidhi, we would want to do a section only for her because I don't think we would be able to plan a vaginal delivery. So you need to make her fit for our anesthetist as well.
Okay, now what are your approach, Dr. Nikhil? Or do you think that you would like to advise them? Would you like to ventilate the patient or intubate the patient? What are the options that we have to stabilize such a patient?
So initially, definitely treat medically as far as possible. I'll not intubate the patient. So during intubation, there's every chance that the patient can go into labor. So as far as possible, I'll like not to intubate the patient. And just coming back to Dr. Srimati's concern, like if the patient has a non-pliable valve, what to do? So one thing that we can do is maybe, so usually if the patient is around 150 or 160 centimeters tall, so we usually use a 25 or 26 balloon to dilate the valve. So what we can do maybe is just undersize the balloon just to bail out, for the pregnancy, and maybe use like a 22 balloon, like undersize it so that the flow is established and will not do much damage to the valve. If that is not the option, then we can go ahead with open heart surgery and putting the patient into CP bypass is always risky, both for the fetus as well as for the mother. So that is one thing which I would like to tell.
Other thing is when the valve is not suitable, that is like submitral apparatus is also involved. So as Nikhil suggested, that undersizing the balloon and partial expansion of the balloon slowly, so that slight relief of this submitral part, and so that patient will become hemodynamically stable. Then we can go ahead with the delivery. Then later on, we can send her for surgery after once she recovers completely.
If this patient's heart rate is something like 120, and you want to reduce the heart rate, what are the options you have, Dr. Srinidhi and Nikhil? And also the fetal medicine experts also can join in here for their opinion as to what is their inputs into this particular scenario.
Yes, sir. So I would like to put the patient on beta-1 selectors. So the only beta blockers I think recommended are metoprolol and bisoprolol. Rest of the beta blockers, if the patient was already taking them, then I'd like to switch the patient to either of them, sir, either metoprolol or bisoprolol.
What are the patient's BP is slightly on the higher side, we can give labetalol also. Both, it will take care of both. But obviously, beta-1 selective will be advisable.
Okay, now you give beta blockers, and fetal medicine experts say that the child may develop fetal bradycardia. How do you want to approach? Fetal medicine experts have any suggestions on this particular scenario that the mother is administered with the beta blockers and they have to address the issue of fetal bradycardia?
So it doesn't cross over so much to cause fetal bradycardia. We've used it also. So all we do is keep a monitor on the mother more than the baby.
So if you're more bothered about FGR rather than actually
so long term, yes.
With growth scans.
Yeah. Okay.
Routinely we don't see fetal bradycardia often with beta blocker. Mother receiving beta blocker. Yeah.
Fair enough. You are happy
in terms of
yeah. Very nice. Now, in fact, this patients were to present in the first trimester. What could be your approach then?
So there again, it is always about counseling. At first trimester, just like the previous case also, since it's the first trimester, the option is very well presented to the patient that since it's an advanced case where already there is orthopnea and PND, she has an option to terminate and go forward with the surgery and then look at her next pregnancy. But yes, there can be certain times precious pregnancy, they didn't know they had a heart problem, they went through IVF, came back. So that again, we will need a multidisciplinary team to tell us, yes, how bad or okay or manageable is the situation, and then go forward. But we would probably counsel towards termination treatment and then getting pregnant again.
Okay, fair enough. In case if this patient were to be kind of, given the benefit of balloon mitral valvotomy in this particular scenario, that it happened to be a precious pregnancy that was being alluded to, fetal medicine experts should comment on the radiation-induced injury to the fetus. Although our cardiology colleagues would like to cover the abdomen and reduce the radiation as much as possible. What's your opinion and suggestions, sir? Fetal medicine experts in this group.
Yeah. Again, it's as already mentioned, it's benefit versus risk. If mother is really at risk and she would like to continue this pregnancy, I think if the cardiologist feel that it's needed, by shielding the abdomen, that should be fine. So we will take that marginal risk after counseling the couple.
Okay.
So anyway, we would be planning after the first trimester, so the chances of complications do come down. So I think we would be okay, and it's always a risk stratification, mother versus the baby.
Okay. Now, in case the lady is symptomatic in the first trimester itself, how do you think that she will not be she will be reasonably asymptomatic in the second and third trimester, isn't it? Throughout the pregnancy, the risk will be continuing and probably it will be becoming more, isn't it?
More than that, I think the risk will increase, sir, because first trimester, the volume will be low. Cardiac output, everything has to go up in the second and third trimester.
Yes.
So I think, as Madam told, it is better to counsel the patients, to terminate the pregnancy as far as possible. Because if in first trimester, when the circulating volume is low, that itself she is not able to tolerate, then very likely that she will have more cardiac complications in the future.
The prepartum, intrapartum, and the puerperium is going to be even more tricky and dangerous for us to navigate.
Perfect. Yeah, I mean, now that we treat heart failures with the diuretics. In fact, any opinion on use of diuretics in pregnancy? Dr. Nikhil or Dr. Shrindi can comment on that.
Yes, we can use it so that we should try to make the patient euvolemic, and then as far as possible, once euvolemic, taper and stop it off. Like we should not continue the same, but in emergency and patient symptomatic, we should use it, and it's for short course of the time.
Loop diuretics we can use.
Happy. Though diuretics, we are worried about constriction of the intravascular barium. Again, it's the mother which who matters here. But only thing is, we would not want you to use spironolactone or the aldosterone antagonist. I think we would prefer furosemide rather than. Yeah.
Yes. Yeah. Perfectly said. I'm glad that it was mentioned, and also with the intravascular volume being higher for the benefit of pregnancy and the fetus, one is a little one should be a little careful. That's all we wanted to bring in. It is not a kind of administering diuretic and forgetting about it in the prescription once it's given. So let's go on to this particular. We already discussed this particular aspect of it. Now we have another patient called SK, chronic rheumatic heart disease with mitral mechanical valve. Although our Dr. Santosh mentioned, and one of the other speaker also mentioned that they would like to offer the bioprosthetic valve, and it has its own issues. Let's not discuss those issues at this moment. This particular lady had pregnancy at 16 weeks, had mitral valve replacement done at the age of 26 years, and on oral anticoagulant and managed well. What are the issues and how to manage these pregnancy? If the patient were to present before the pregnancy, what is the ideal approach then? Let's go to the obstetrician first. Kindly comment on when we allow the pregnancy to occur in a patient with a mitral valve replacement patient. What are the precautions that they would like to take, or would they like to take the help of a cardiologist at this stage itself?
So yeah, sorry, go on.
Warfarin is one of the things that we wouldn't want in the first and the third trimester. So one thing that we would want them to do is change the oral anticoagulant and make it into heparin, either to continue throughout pregnancy, preferably to be done prenatally rather than antenatally, and then continue throughout the pregnancy, or at least change for the first and the third trimester. And to make sure that the other thing is that the situation should be reassessed. So she has to have a baseline echo at that point of time and understand what is the current situation when we are starting the pregnancy, teach them what can go wrong, and keep them monitored at least every trimester to have a visit to the cardiologist and relook into what is going to happen with the heart.
I want to even carry on with oral anticoagulant. Sorry to Bhajan, but based upon the dose, I think again it's risk-benefit ratio, because she's already 16 weeks and she's been on oral anticoagulants. I would rather carry her on with oral anticoagulants because that is going to be safer for the mother. And it also depends upon her past history, because if she's had any valve even before valve thrombosis, then again I would be more anxious. So I would probably at 16 weeks, whatever has happened with oral anticoagulants, I would rather continue on this for now. But yes, peripartum, the third trimester at around 34, 36 weeks, I might want to switch her over to LMWH. But as of now, I will keep her on warfarin. And yes, as per the latest guidance, if the dose of warfarin is less, even in the first trimester, they say we could carry her on.
Then 5, we can still continue.
Yeah, I think again, it's a risk-benefit discussion which we need to have with the couple because of the small risk of warfarin embryopathy. But I think the mother again comes over the baby.
I want somebody, fetal medicine expert, to talk about the oral anticoagulant, warfarin, or a kind of vitamin K, coumarin-based and rather anticoagulants versus the fetal outcomes. Please comment on that particular aspect of it, because it is not just about stopping or starting. It is supposed to be on the basis of some signs.
Embryopathy.
Yes. What is this embryopathy and how often does it occur?
Yes.
Go ahead, please.
Yes, nowadays warfarin, of course, theoretically can cause the teratogenetic effect and fetal warfarin embryopathy. But fortunately, we are not seeing these cases commonly, thanks to cardiologists and the good cardiac, care and counseling up. I think with high doses periconceptional and in the first trimester, warfarin can cause the damages at the time of organogenesis. Mainly, it can cause the hypoplasia of the nasal bone and facial appearance, hypoplasia of the frontomaxillary aspects, epiphyseal stippling, and it can cause bleeding as well, and that the placental bleed or the bleeding can cause adverse side effects. It can cause even stillbirth or miscarriage as well, as if the bleeding is severe. So, and also it can cause the bone growth. It has got some bone inhibition factor, osteocalcin. It inhibits osteocalcin, and it can also lead to intellectual disabilities and small head size. Like that, we can list many findings.
Unfortunately, this patient came at around the age of 16 weeks of pregnancy. Do you have any concerns about this pregnancy, about termination? In general, when do you recommend MTP, for instance, in a patient with a cardiac disease? It is a broad question, but let's not bother about it. About this particular patient, as she has received the oral anticoagulant, and you find something abnormal in the fetal scan, do you want to elaborate about the fetal scan and the care of this particular patient? Fetal medicine experts, please.
Yes, of course. As I mentioned, there is like facial features or looking abnormal, hypoplasia of the nasal bone, and the head size is smaller. And if you are sure that dates are correct, and there is at this stage, I don't think we can assess the functional assessment like intellectual ability, all those things. But if there are any structural abnormality, definitely we will discuss with the patient and will give this input to obstetrician. And at the end of the day, if the patient doesn't want to take any risk, obstetrician has to decide in terms of termination.
Yeah. Now let's listen to obstetrician, what they want to advise in this particular patient in case the fetal medicine expert says that it is up to them to decide about the termination of pregnancy.
So I think it depends upon what the patient wants, because the risk of embryopathy is not 100%. So if there are concerning features, if they have identified a fetal abnormality, then I think it becomes, sort of a counseling what the woman wants. But if there are no abnormality found, then I would say whatever has happened is okay. We have not found any abnormality. We'll keep a close eye on. And if the patient wants to continue, I would rather continue with the pregnancy. But of course, definitely at around 34 to 36 weeks, I would want to switch her over, because obviously peripartum, I'm going to be in trouble if she's going to be still on warfarin. But if there are no identifiable abnormalities and she's past the period of organogenesis, then maybe, my counseling would be more pro towards carrying on with the pregnancy.
Would you like to take any kind of a detailed consent in your practice in this particular situation?
Yes, sir. I think this is definitely a high-risk one, and we would need to tell her that, as Dr. Praveen was telling, few of them could be identified.
Telling is one aspect of it, ma'am.
Yeah.
Documenting is another aspect of it. This is our approach.
Yes, sir. So we do document and say that what could be the prognosis and what kind of a care the baby might need later on. So all of these would be documented, but of course, it is the patient's choice. But we would need to tell them, and maybe even having a expert opinion from the NICU, the NICU team, having a discussion with the neonatologist and the pediatricians, so that they would know what to expect for the baby. And then they make a, sort of a decision, because this is what we do for any abnormalities. We get the NICU, the team, to be involved, so that they would be able to, sort of be aware of what the long-term prognosis is, because it's not just a short-term, it's going to be the long-term for the child.
This particular patient has a mechanical valve. And how about the infective endocarditis prophylaxis? Dr. Srinidhi or Dr. Nikhil can comment on that.
Yeah, sir. So patient has a mechanical prosthetic valve, most likely rheumatic heart disease. So patient definitely warrants infective endocarditis prophylaxis in this situation. So I would tell them to go ahead with the normal infective endocarditis prophylaxis that has to be given before vaginal delivery or before C-section, sir.
Fair enough. Now, how about the pre-part? We discussed this pre-part.
So just about the IE prophylaxis. If the patient comes with, at leak we give, at before section we do give. But if patient has any other illnesses during the 9 months of pregnancy, say for instance, she has a bad dental carie or she has a bad vaginal infection, which we treat as vaginal infection, most likely fungal, do you really need to give the IE prophylaxis as it is for them?
About your opinion, Dr. Nikhil, do you have any suggestions?
So before dental procedures, if the patient has a mechanical valve, then yes, I will recommend infective endocarditis prophylaxis. Regarding vaginal infection, I'm not sure. I think unless you're doing some procedure, I don't think you're causing any bacteremia. I don't think it is necessary in that situation.
Any difference of opinion, Dr. Srinidhi? Would you like to add on any opinion? If there are none, I'll go ahead. Okay. All right. We have already discussed all this. This is a little long story, but unfortunately, as there is not much of time, this particular lady missed the closure of the defect called VST when the child was born. She herself was born rather 24 years ago, and she went on to have pulmonary hypertension, and she became pregnant after getting married to her maternal uncle. In fact, unfortunately, she came late in the pregnancy, and we had no other choice except to say that diagnosed as Eisenmenger syndrome and pregnancy and advanced pregnancy. At this stage, what is the obstetrician's approach to this particular patient? Obstetricians, please join us.
So with Eisenmenger syndrome, as we heard in the previous talk as well, we are worried about both the mother as well as the baby, but of course the mother first. So higher chance of mortality, morbidity, because obviously they're going to have pulmonary events, and we are because pregnancy being an hyperdynamic event, it is going to cause complications. But as you said, sir, she's now already sort of advanced pregnancy. So I think it's trying to see how we can. So obviously she might have to be admitted inpatient in a cardiac obstetric unit with MDT care, and then plan her delivery. So I think optimizing her health so that we can plan her delivery. Of course, the baby is also going to be at risk because of the decreased oxygen saturation, so FGR and the other associated complications, and also the congenital cardiac defects that could be inheritance. So obviously at that point in time, again, 32 weeks, how much we can actually identify the abnormality also is a bit tricky. So again, as we discussed earlier, sir, we'll have to have a discussion, having high risk consent, having a detailed counseling, having an inpatient care, trying to optimize our health, and then plan a delivery, and of course then advise her not to have future pregnancies, and plan her contraception, and close watch in the 4th trimester, that is in the puerperium, because that is where the cardiac events are going to be really sort of happening.
Wonderful. In fact, the child was born, and the child was healthy, and happens to be young girl. As this couple walked into my office, and she wanted to announce this. She has been pregnant again. Very unfortunate. And it looks like our obstetricians did not do a good job when they delivered her, because this particular patient was under care of an obstetrician. And she did not come back to me, and when she came back along with her child, it was very, very unfortunate. And that is the patient and her husband. She wanted to have this continued pregnancy, and my God, it is terrible thing to happen. And of course, she did not. Fortunately, we terminated this pregnancy. And of course, this particular cyanosis can be easily missed in dark-skinned people. Now that pulse oximetry being available very easily to all of us, I hope that many of us use this pulse oximetry in the clinic when we examine our patients, because mild cyanosis, which is often seen in patients with pulmonary arterial hypertension, may be easily missed. If a clinical examination is rather tardy, one can easily miss in the busy clinical practices. Now, this particular patient, I need to answer safety, that is bad. Care of patient, it is tough. And peripartum care is even tougher. Would you like to deliver this patient by cesarean or by vaginal delivery? Obstetricians, please.
So if it's a severe pulmonary hypertension, then again, normal delivery might be a bit tricky. So C-section may have to be indicated, because if she's having severe pulmonary hypertension, which has resulted in Eisenmenger syndrome, so vaginal delivery might be a bit tricky. So you might have to plan C-section for her. And of course, anesthetic considerations and section considerations, and peripartum period is going to be very difficult. So if I had an opportunity, I would have definitely thought about termination, at least for the second time when she came in early pregnancy.
Yeah, her second pregnancy was not continued. And of course, the first, if this patient were to be presenting to us before conception, definitely the options that have been already presented to the patient and their family. Now, if this patient's, this particular shunts and valves abnormalities are heritable, we already have discussed this particular patient. Friends, because of the lack of time, I'm not able to continue beyond this point. Indeed, we reiterated the concepts that have been driven by the three previous speakers beautifully. And I thank each individual panel on this particular session who have answered their questions very brilliantly and brought in the practical aspects of it. And I hope this was very useful to you. And it was an additional learning for many of us, and especially for me, and for the opportunity given to me. On behalf of all the panelists, I thank the organizers, and back to Dr. Hema for her proceedings. Thank you so much.
Thank you, sir, for giving us valuable points and being having us as part of the panel. And thanks, Srinidhi and Dr. Nikhil, for your wonderful inputs. It was really a good learning session for us, and I hope everybody benefited with it. Thank you, sir.
Thank you so much. Thank you.
Congratulations, Dr. Nagaraj sir, and all the panelists for this wonderful discussion. It was indeed very nice to hear to all of you with a good amount of discussions. You've touched upon almost all the points of cardio-obstetrics, starting from the congenital heart disease to the acquired. And I think you left on the ischemic heart disease. We might get patients in the present days, because that is also upcoming now. Like the woman would have had some kind of a myocardial infarction, and she might need some amount of a counseling when she plans to plan her pregnancy. Your points on that, sir?
Yeah, in fact, of course, I had very rare opportunities to see one infarction during pregnancy, in fact, very, very rare. And of course, when the patient comes to us with regular ischemic heart disease syndrome, we treat, and subsequently they become pregnant and receive stents. I must mention here that there was a question on the stenting, and followed by patient becoming pregnant. It's a very dicey situation, especially early discontinuation of antiplatelets, especially if the patient happens to have multiple stents. You will be taking risk. Again, the risk of benefits and the bleeding that we have to manage. And if it happens to be a single stent which was placed about at least 1 month earlier, it could be different. And the heritability of the genetic abnormality associated with many of these antiplatelets has not been very, very powerful enough to caution the clinicians. So suffice to say here, at least, single antiplatelet should be at least continued. And many of our surgeons are happy to take care of our patients, even for coronary artery bypass surgery, to plan. And obstetricians also should be willing to take that kind of additional risks of bleeding. And uterine bleeding, anyway, you are experts in that. And of course, if it happens to be the bleeding into the child's issues, it can be an issue. So in other words, the management of obstetrical heart disease should not be limited to rheumatic, should not be limited to valvular and congenital heart disease, but we should go beyond, because a couple of my patients that I was planning to present to you guys was on non-valvular and non-rheumatic and non-congenital. But because of lack of time, we could not continue that particular discussion. Thanks for that question. Thank you.
Thank you, sir. Thank you so much. Unfortunately, all of our patients would not be readily acceptable for this kind of a genetic evaluation. And we might keep seeing such kind of patients in our near future also. Thank you so much for your moderation, as well as I want to congratulate all the panelists for the wonderful discussion. Thank you. Thank you, everybody. And I also would like to thank the Society of Maternal Fetal Medicine, the Mysuru chapter, for giving an opportunity to be an expert for this panel discussion. Thank you.
Thank you.
Dr. Malini, your inputs, please, as an expert.
Thank you for the variety of cases, sir. We have touched upon every possible scenario, and the discussions by the cardiologists were good. I myself had some learning points from this panel discussion. Thank you so much. And thank all the experts, obstetricians, fetal medicine consultants for giving their valuable inputs.
Thank you so much, sir. And we have Bharti ma'am staying with us from the beginning till the end. So this gives us an impression that our conduction of this webinar has been a great success. So, and we have exuberant participations of more than nearly 350 delegates logged into this webinar. And of course, today's discussions, all the topics we have touched upon. So cardio-obstetrics being a huge, and we'll be coming up with subsequent sessions. So please be prepared. Next sessions will be presenting on late obstetric complications and labor managements. We'll be announcing the dates soon. To summarize, so very importantly, we need to be having a very highly suspicious, and you should be low threshold of investigating a cardiac disease. Multidisciplinary approach is mandatory. And of course, try to, whenever the facilities are available, consider utilizing the services of genetic counseling. And nowadays, it is not a single disease. So patients will have other pre-existing conditions, maybe hypertension, maybe diabetes and anemia. So many others will add to the complications of the cardiac disease. And we as an obstetrician should team up with the multidisciplinary team to avoid the fetal and the maternal complications as well. So the great team of all of you have made this program very successful. I thank everyone. And over to Bharti ma'am for your input. Later on, Shweta can take over.
Thank you, Dr. Sushma. I have no words to express the quality of discussions that went on today. As you rightly said, though it is on a Sunday morning and the weather here in Hassan is so cool and salubrious that I would like to go out for a drive, but I kept glued to my laptop screen because the discussions going on were excellent, because this long needed webinar, I would say, because we've been discussing of all the common problems. But this cardio-obstetric theme that you selected and the faculty members selected have given their excellent inputs, and they made it so clear and so simple that next time we do have any of these cases, we will definitely do the prenatal examination and counseling we need to do. That is one thing very, very important, preconceptional counseling. And then how to manage in case whichever trimester they come to. And I think the apple on the cake was the cherry on the cake, I would say the panel discussion, excellent discussions, and looking forward to having much more of these sessions, because it definitely gave us a very focused approach to managing cardiac disease. And I congratulate all the eminent faculty members here. And it was indeed a pleasure to see Dr. Nikhil, who I have seen as a child. He happens to be a very close friend, Dr. Basangodappa's son. And we have been seeing him since a very small child. And it really gave me a lot of pleasure to see him on this panel. Congratulations, and keep going on. And there's much to be seen and much to be heard in the future also. Thank you very much.
Thank you.
Thank you, ma'am, for your encouraging words. And thank you, a very big thank you to Dr. Nagaraj Desai sir and all the experts and the panelists. I now request Dr. Shweta Nayak to propose the vote of thanks.
A very warm good afternoon to everyone. This session was really wonderful, and we had a brainstorming session. And after a long time, we enjoyed discussing cardiac disease during pregnancy. First and foremost, I would like to thank Dr. Bharti Rajshekhar ma'am for sparing your extremely precious time with us and sharing your experiences. It was really wonderful. And I would also like to thank to Dr. Prakash Mehta, who is the brain behind all these sessions. He is the power behind this SMFMI, and his suggestions are really wonderful, and it is really nice to be working under him. The real beauty with brains behind these sessions, Dr. Mamta and Dr. Sushma, I would like to thank them as well, as they were the foremost brain running in all these sessions. I would like to thank our speakers, Dr. Mali Sukayogula and Dr. Santosh K and Dr. Deepa Bhatt, for your wonderful presentations over the topics. They were really helpful as a private practitioner. My knowledge regarding these subjects are freshened up once again. And as Madam said, cherry on the cake was panel discussion over cardiac diseases during pregnancy. Thank you, sir, Dr. Nagaraj Desai, sir. It was really your expertise in these subjects, and these topics have really helped us to learn a lot more in these topics. I would like to thank our own Sunanda ma'am, Dr. Srinidhi Hegde, Dr. Anu Joseph, Dr. Srimati Raman, Dr. Praveen NS, and Dr. Nikhil Basangodappa for extending your expertise in talking over this topic.
Last but not the least, I would also like to thank Mr. Shrikant and his team from MQ Pharma, Inventia Division, Orofer FCM, for extending their services into organizing this session. We had around 283 registrations and logins. It is indeed a successful session. I thank you one and all. Thank you.
Thank you, everyone. Thank you, all the faculty members, for joining us. Thank you, Hema, for teaming up and taking care of all the communications with the faculties and being one of the strong leader and member of our society. And thanks, Shweta, again. So we'll be shortly announcing our next sessions. Please be tuned and join us with more numbers. Thank you, one and all.
Enjoy the rest of your week.
Yeah.
Have a healthy heart. Thank you.
Thank you. Have a great weekend.
Bye. Good night. Good evening.
Thank you, Hema.
Thank you.
Have a great Sunday. Bye, everyone.
Thank you, Hema and Sushma ma'am. Thank you.
Thank you. Thank you.
Yeah.